So, ladies and gentlemen, welcome to the Breast Education Series. And my name is Foma Munoh Kenne, and I'm going to introduce myself. This is in partnership with the Cameroon Town Hall for health professionals. And the goals behind this is to have a 2-day lecture series on breast cancer. So I would just start by sharing my slides. So who am I and why am I talking about breast cancer? That's very important that people who are here for the first time. I am a medical oncologist, so I'm Dr. Munoh Kenne Foma. I actually schooled in Cameroon. I went to the Faculty of Medicine and Biomedical Science. I did 7 years there. Later on, I worked in the regional hospital in Bamenda. For 2 years, I had experience in Cameroon. I worked in the regional hospital. I also was a director of a district medical hospital in Cameroon. Later on, I did specialization in Cameroon as a clinical pathologist, and later on have a master's in public health, moved to the US and did internal medicine. After doing internal medicine, I did hematology and oncology. And presently I work with Presbyterian Health System. I just moved from New York City. I'm presently in Albuquerque. And I see a lot of breast cancer and hematological malignancies and also solid malignancies. I see over 100 malignancies, but I tend to see breast cancers, almost 20 cases every week. So I think in terms of cancer, I have the privilege that I've seen a lot of cancer patients. And today we're really going to talk about how to prioritize breast cancer, get it to a point where medical students need to know what to do. Because I think everyone needs to be held accountable in our healthcare system. And last week in the town hall, I did a presentation. I think I was very critical of the health system in Cameroon, and I think it was a time to do so. Why? Because we have to make sure that we start teaching our medical students, our nurses, and gear them towards non-communicable diseases and also the burden of cancer that is existing in Africa and that's growing. So I thought that was the right time. So without wasting more time, today we're going to start with Model 1. It's going to be a 2-day series. I'll try to make it as light as possible. And Model 1 is going to deal with screening, local management of breast cancer. And my disclosures, this has nothing to do with the hospital where I work for, the health system. It's a very strict health system, Presbyterian Hospital. And so these are my opinions. And they are facts, which have been, my presentation is geared on clinical trials, evidence-based medicine. And I think that's what our medical students have to be taught right now. Evidence changes every day. And if you're a doctor and you're not keeping yourself up to date, then you're going to perish. So we need to update ourselves. The first thing is I made some pool questions, but I'm not going to do them as a pool, just for the sake of time. The first thing is for us to understand what we're going to do here today. I just want to start with some few questions. You guys think about it, and you can actually unmute yourself and shout some answers, okay? All of the following increase a woman's risk of developing breast cancer, except prior biopsy showing atypical ductal hyperplasia, late age of first birth, alcohol consumption, breast implant. So this had to be a poll, but I just canceled the poll. So the answer for this question is important that you know breast implants do not increase a woman's risk of developing breast cancer. So the next question is going to be, breast conserving therapy is proven alternative to mastectomy in the treatment of which of the following? Multifocal ductal carcinoma in situ. What do we mean by multifocal? You have ductal carcinoma in situ is a mammographic diagnosis. If we don't do mammograms, we will not discover them. But if it's multifocal, you need a mastectomy. localized early stage breast cancer. That is true. Patients with diffuse scleroderma on active treatment. No, with scleroderma, you cannot do radiation. You have to always be able, if you're doing a breast conservative surgery, radiation has to be part of it. We're going to really talk about principles. To me, this is very important because if you don't understand principles, even if you are the best surgeon, you'll do the wrong thing. And I've had multiple cases in Cameroon which I question, and that is why our doctors are getting sued now. And a lot of them will not pass the test of the legal system. Patient with positive margins following a lumpectomy needs the margins to be negative, needs surgery. You cannot do it otherwise. And that is why pathology needs to get its act together and be able to help the surgeons and the oncologists and the general practitioners, give them the right information. Now, this is the next question. All of the following are true with respect to centenary lymph node surgery, except tracers can be injected in a subareolar or peritumoral location. That is true, but we don't even do that in Cameroon. These are old technologies back in the 60s. It's amazing that we cannot do this and do appropriate centenary lymph node dissections. And we get all women to get axillary lymph node dissections with all the complications. We should be able to question ourselves now and move forward. It is not associated with risk of lymphedema. That is wrong. It is associated with risk of lymphedema, even if you're doing a centenary lymph node dissection. I know a lot of people will be asking here. There are a lot of people of different levels of knowledge, so they don't even know what centenary lymph node dissections is. Now, there is upstaging of patients through detailed pathological assessment. Yes. If you do that, you can upstage patients. And that is why pathology had kept insisting we cannot have good cancer treatment in Cameroon without a good pathology department. I have the privilege to have passed through most of these sectors in Cameroon. I did a fellowship. I did a residency in Cameroon before moving to the US. A lot of people ask me, why do I say this thing? Because I know Cameroon. More than maybe 50% of the doctors who are here, the different levels of healthcare system, I know it very well. So I've worked at the regional level, the district level, residency in Cameroon, and so I do know, and I've worked in pathology and in the public health sector. Selected patients with a positive centenary lymph node can avoid complications of axillary lymph node. That is true. Now let's go to the next question. A 45-year-old premenopausal woman has recently had a breast reduction surgery with an incidental finding of lobular carcinoma in situ. You could recommend which of the following? Remember, this is what we're going to talk about. This is going to be very detailed. So she is 45, she is premenopausal. Please do not give her an aromatase inhibitor. If you guys know what an aromatase inhibitor is, don't give her exemestane unless you're doing ovarian suppression, meaning you're giving her Lupron. And so the first one is wrong. Roloxifene. Roloxifene is also wrong. We don't give it to premenopausal women. Unilateral mastectomy to remove LCIS. No, please don't do that. LCIS has no treatment. You do not do mastectomies for them. You do it for DCIS, not LCIS. Tamoxifen, yes. It's approved for premenopausal women. And so this is really the goal behind this. The last but one. This same patient is started on tamoxifen. After 5 years, she is premenopausal and no other breast event. What do you do with her? So just not to waste your time, in a patient like this, you don't do anything, please, you discontinue endocrine treatment. So the reason I'm going with these questions is a lot of people think that just by doing and being able to do surgery, then you can take care of breast cancer. You cannot. You need to get yourself educated. There is one myth in Cameroon which I'm going to debunk today, and others who hate me for it, but gynecologists are not breast surgeons. The breast does not belong to gynecology, please. The breast belongs to surgeons. Surgeons need to step up. And the breast surgery is a subspecialty of breast surgery is a subspecialty of surgery. And the surgeons need to get educated on that. so that they can help patients. If you leave that to the gynecologists, they are trying now, it's maybe been a cultural thing, things from Professor Doe Anderson, but it should not happen. That is why we're having poor outcomes in Cameroon. One of the main reasons is that the wrong specialty is trying to take care of patients who need to be taken care by another specialty. So, a 57-year-old woman with DCIS with microinvasion, there is no ink under the tumor. Is she considered to have adequate margins? The answer is no, please. But this is a technical thing. You have to have at least 2 millimeters margins on DCIS. While with ductal carcinoma, you actually are not with invasive carcinoma, you don't need 2 centimeter in ink margin. And if you have a bad pathology department, how do you know all of these things? These things become fluid, and medical students have no idea about what they are going into. So breast, like any oncology specialty, is a teamwork. It's a team sport. I'm a medical oncologist. I don't do it alone. You need to have other team members in the sport. You could be very, very educated, but your other team members lack the basic education to help you in this team sport, and you are Onana, you have all the goals in the world. You're not going to end up being better. So in any breast oncology, it's a team sport. All of these specialties need to be involved. There is this book which I'm going to talk about to medical students, The Emperor of All Maladies. It actually tells you the history of cancer, but lays particular emphasis on Horsteck's mastectomy, which is something I would insist on. Surgeons were the first specialists to ever attack oncology, followed by radiation oncology, and medical oncologists were the last to come in. The surgeons had the belief that by cutting everything, you're going to cure patients. It's not true. We have had clinical trials that have proven that over and over, but I still find radical mastectomy being done in Cameroon is not acceptable. Now let's go to epidemiology. Yeah, I'm not going to lay a lot of emphasis. It's just to tell you breast cancer is the most common cancer in women in the world in Cameroon, and #1 killer in Cameroon. In the rest of the world, lung cancer is still #1 killer in the US. Here you turn, this is a very important landmark presentation, which I want to show. Majority of breast cancer is estrogen and progesterone positive and HER2 negative. Please note this. Why should you note this? Because we are unable to do histochemistry staining for all patients. We do it at Centre Pasteur in Cameroon. Some people send it out, which is good, to the US, but it takes a time for it to come back. And there's always this controversial question: if a metastatic patient comes to my office with this, what should I do? Should I start on chemo? Should I start on hormonal treatment? But this helps you as an oncologist, that you know that 70% of them, actually the majority, are estrogen and progesterone positive and HER2 negative. So what I say is, nobody who has not done a histochemistry staining in Cameroon should die without getting hormonal treatment. I've seen a lot of cases that have come to my notice, but it should not happen. I think those patients did not meet medical oncologists, but these are things that should not happen. Test them. I was in La Cantini for one of the tumor boards, and I made a comment: you cannot keep complaining to me that doing an IAC is expensive, why a round of chemotherapy is about almost 250,000 to $1 million, depending on what kind of chemotherapy you're giving. By testing the IAC, the patient may not need chemotherapy, may not need it, and may never even need it, may need it later on, and you would help save their lives more by doing that. So throughout this lecture, this particular theme is going to be hammered, so that I want it to sink into the heads of the general practitioners so that they can hold the rest of the system accountable. So this is data showing survivor. This is common for US, for Europe, because we screen patients. Now that we screen patients, majority of our patients survive. The estrogen and progesterone positive breast cancers are still the ones that do the best. And here you can see data that is subdivided into Blacks, Latina, whites. Whites still have the highest prevalence of breast cancer, but they have the best survival. while triple negative breast cancer is more common in Blacks than any other subgroup, and we should know that, and Blacks die more from breast cancer. In the US, it's due to multiple reasons, but in the rest of in Africa now, it's actually because we are not diagnosing them early. We don't have any screening protocol in place for most of our countries. Cameroon does not. And I think it's time for us to adapt that rather than trying to treat this patient. Rather than the popular belief that everyone thinks that breast cancer is very common in the young, because we see a lot of young women and we are very emotional about it. And in Africa, it's slightly more common younger women, but breast cancer is a disease of aging. The more you get older, the higher your odds ratio or your risk ratio for getting breast cancer. Today, I'm not going to show the slides I showed during the town hall for multiple, just talk about risk because we have other important things to talk about. It's important to know that BRCA gene and other genetic factors can increase your risk of breast cancer 10 times. There is BRCA1, BRCA2. BRCA1 is usually involved with breast cancer, ovarian cancer, and BRCA2, you have pancreatic cancer, prostate cancer. So you should, and it doesn't skip generations. So while taking histories, you guys need to, the general practitioners, please, you screen women at the age of 30. When you see them, ask them these questions. Early menarche. There is the rainbow syndrome, which gynecologists will tell you about. Early menarche, late menopause. Usually it's a risk factor. They are exposed to estrogen more. Late age at birth of the first child. You have benign breast lesions, which we're going to talk about some of them. Hormonal replacement therapy, alcohol, family history, all of that. Now, BRCA is high risk for breast cancer, but it is responsible only for about 5 to 10% of all breast cancers you would see. We don't have data in Africa. There are other genetic syndromes like Lee-Fraumeni. For some strange reason, it looks like Lee-Fraumeni could be common in Cameroon. I've had 3 Cameroonian girls in the US who had breast cancer young and were all positive for Lee-Fraumeni. I was very shocked. So it could be one of those genes circulating that we don't know about because we don't test. There is the CDH1, which they have gastric cancer and lobular carcinoma and PALB2. So there is another thing in, if your pathologist sends you a report and tells you the patient has lobular carcinoma and tells you that it's estrogen and progesterone negative, please call them to question. 99% of lobular carcinoma is estrogen and progesterone positive, that hormonal treatment. Okay. So there are factors that do reduce risk for breast cancer, like breastfeeding. It doesn't mean this is breastfeeding for women who are pregnant, because during that time, it stops exposure of estrogen. This is and progesterone. So there is time during breastfeeding, you are also amenorrhea. There is age less than 20 years of first pregnancy. There is history of ovarectomy because you're taking away the estrogen. There is also exercise, which is important. Here, I would just state that most breast lesions increase the risk of breast cancer, except for cysts, fibroadenomas, ductal ectasias, and mastitis, which is just inflammation of the breast. But if you have anything with your breast, please get to see, and it lasts for more than a week, get to see a specialist for them to examine it. So atypical hyperplasias and lobular carcinoma in situ do increase the risk of breast cancer. So these patients actually need to get screening, and some of them may need prophylactic treatment. So preventive therapy, this is something that is hardly done. Even in the US, few women do get preventive therapy because most of this is done by breast surgeons. Once they get to meet breast surgeons, they get this, but because of access, so high-risk breast lesions, patients who have a Claus or a Tyler-Croson score or a Gill score, which is high, and high-risk patients can be placed on breast preservative surgery, on breast preservative medications. These are all the clinical trials. For today, I will not go through them, but I'll have them in my slides. So there are several trials that have shown that women with high-risk lesions can prevent them from getting breast cancer by prophylactically treating them with tamoxifen. This is the trial, and this is showing the reduction for those who do not get tamoxifen. This is the NSABP trial. So what is the NSABP? The NSABP is actually the National Surgical Adjuvant Breast and Bowel Project that was started by the NCR. They made the biggest breakthroughs in cancer back in the 70s and the 80s. So they have wonderful trials. Most of the trials in breast cancer I'll be talking about today are the NSABP trials. These were the trials that put an end to Hostek's barbarism. Hostek was an excellent surgeon, but it ended the barbarism of what we used to do to women. So let's go to look at this. The other thing was the STAR trial that shows that you can also use roloxifene in place of tamoxifen for prevention. This is prevention. I'm still with prevention. But roloxifene is not as good as tamoxifen. You need to know that. I will not go into the details here because it wastes us a lot of time. But those who are specialists, I can give you my slides. I know some oncologists are here so that you can look at them. And it helps you to know that we can still use this, and it reduces invasive breast cancer and non-invasive breast cancer. And roloxifene is better than tamoxifen in preventing uterine cancer and thromboembolic disease. Those who have used tamoxifen know that there is a risk of uterine cancer and there's a risk of thromboembolic disease. So this trial actually did help show us that. There are other trials that I'm going to talk about here, which later on showed that we can use an aromatase inhibitor to prevent breast cancer. So here is one of them, which actually shows, but you should be careful. These are all menopausal women. Never use an aromatase inhibitor in premenopausal women because you are not going to do anything. You have to use it and add. You have to add an ovarian suppression medication, but in prevention, we don't use it even. So there is also anastrozole trials that show it. In summary, for prevention for breast cancer, you can take women who have high risk and you can give them anastrozole. You can give them exemestane, letrozole, tamoxifen, roloxifene for all those who are postmenopausal. Those who are premenopausal, the only thing you can give them for prevention is tamoxifen. I hope everyone understands this. So this is the slide that really summarizes this. Don't give it to women who are less than 35. They were not involved in the clinical trial. And for premenopausal women, only tamoxifen for prevention, those who have not yet had DCIS or breast cancer. I know this information, I don't want you to confuse people. This is prevention, prevention, and prevention, prophylactic prevention. Now for screening, let's go to the next thing in our discussion. I think this is where the Cameroon government can do a lot. And this is where our general practitioners need to be educated a lot more about screening. What are the guidelines? These are the guidelines in the US, which are not very practical back home, because in the US, we start screening at 40. But there is controversy and a big debate. So I am from the American Association of Oncologists. We do start at 40. We advise 45, you get it every year. Once you're 55, you get it every other year. And we advise against self-breast examination. There have been multiple trials that have advised against, and I'll explain why. In the Cameroonian context is different. The reason is that in the US context and Europe, when women do self-breast exams, they tend not to do mammograms. And they feel they have nothing, but we want to catch cancer at the earliest stage possible. No doctor's hands is as good as a mammogram, please. And because screening is free and covered by the insurance, so we are advising against self-exam, but we advise against for self-breast awareness, which means a woman can examine her breast the way she likes and look at it. If there's any changes, she should talk to her doctor. But in Cameroon, because we are not screening, most breast cancers are actually diagnosed by clinicians and by women who see that they have lumps in their breast. Most of the time it's late and it's late stage. So these are other recommendations really, but I have laid emphasis on what is important. This is a task force. In Cameroon, I think what we should adopt is the WHO recommendations. Start at 50 and examine and do mammograms every other year. Please, any general practitioners should note they start at 50, do mammograms every other year. You're going to save women's life. Another thing is an MRI. I will not talk about MRIs today because we don't even have them available. We have 4 functional MRIs in Cameroon from the government sector, and I know where all of them are. I try to keep myself up to date with Cameroon. So there is, in Yaoundé, there is a military hospital. In the rest, CSU has not been working since I left CSU in 2010. It has not worked up to today. L'Hôpital General does not have one. It's not working. L'Hôpital General Douala, I think it's not working now. The Clinic Munoh has one. There is one in Bafoussam in the new hospital that was created. There's one in Gandere, and that is it for government hospitals. So it's sad and it's pathetic, but I'm not going to talk about this, but there are recommendations for us to get MRI screenings, but we cannot even do a mammogram, so I don't want to insist on MRIs. They are not going to serve us. So the purpose of this really is to tell us that there are some genetic factors that we are not testing in Cameroon. We don't have capacity to test them, but those who have the money and want to test it and have family history, please send them out. Some of them can get it done outside. So now diagnosis and staging. This is where I would stop for the surgeons a little bit. The objective here is to discuss methods of breast biopsy. Please, guys, stop doing an FNA on women. Do you guys know what an FNA is? A fine needle aspiration. You can do it in poor resource countries like Cameroon, but please, you guys have enough money, most of the surgeons I know here, to order a core needle biopsy. The reason why an FNA is bad is that if you biopsy an FNA, you need a good cytologist, not a histologist, to study the cells, point number one. Two, you cannot do histochemistry staining appropriately. Three, you don't get the architecture of the cell. Four, you are going to be unable to differentiate DCIS from invasive carcinoma in situ, because invasive carcinoma, because you don't have the membrane. I'm saying this because I worked in a pathology lab. It's useless unless you are finding yourself in a situation. You can FNA a lymph node, because if a lymph node is positive, with an FNA, ductal carcinoma in situ do not go to lymph nodes. So that tells you the patient already has breast cancer, but not FNA a breast lesion. Now, core needle biopsy is the gold standard. That's what we should be doing. I was very petrified and a bit disappointed when even a medical oncologist was asking for histoimmunochemistry staining, but did not take note that the patient actually had an FNA. And this is why we should be telling our surgeons. A punch biopsy, which is something done a lot by dermatologists, can also be done, especially those who have inflammatory breast cancer. You can do a punch biopsy. Excision biopsy is not advised, but we do a lot of excision biopsy given our conditions in Cameroon where they do excision. The problem with excision biopsy is that you're going to, if you are a good surgeon, you may have to go twice. You have excised the lesion most of the time. Just the pathology reports need to be appropriate to tell us if the margins are positive or not. So this woman will have to go through surgery twice. And you will not be able to do centenary lymph nodes and a lot of other things. So this is just how a fine needle aspiration is done. I will leave it in my slides. I don't advise it. There's what they call the French technique, where you can take the needle and you poke on the lesion multiple times, and then you aspirate. There are multiple techniques to do it. During my training, we're trained on this, but we don't do all of this most of the time because there are others. This is what you call a core needle biopsy. This is supposed to be the gold standard, and take as many calls as possible. You would help everyone. You will help the pathologist. This is the gold standard of what needs to be done. We can do immunohistochemistry stainings appropriately on this. And I said this, no woman with breast cancer should not be able to do immunohistochemistry staining unless they are really poor. It should be a gold standard on all. And that is really my message in this whole talk for the general practitioners. This is a punch biopsy that can be done, especially if you come in with a woman who has inflammatory breast cancer. You can actually do a punch biopsy of the skin lesions and test them, because in this case, anyway, you're going to do a mastectomy. That's the standard of care. And these patients will need chemotherapy. Now, when it comes to excision biopsy, we do them. You do them under general anesthesia. The problem is that it allows us to get histology. It allows us to get everything we want, but we may have to go again. We usually have to go again, and this is never right because, and in Cameroon, a lot of excision biopsies, pathologists are not sent. So this is something we need to work on. Now, for lymph node biopsy, this is where the biggest controversy comes. Centenary lymph node biopsy is something that I don't know how many doctors do it, but now this is supposed to be the standard of care, where you're going to inject radioactive and substance and dial. You use a probe, you're able to know the lymph nodes. Then the lymph nodes that have the dial, you're able to take them out and send them out for proper staging. This is really what the standard of care is supposed to be. And this is not complex technology. I always said, if you cannot have radioactive material, you can use one of them, the dial. I'll show you studies here that show that both of them are almost equal, though dual modality is better than one. But please, this is where I want advocacy to be placed in Cameroon. We cannot build hospitals for billions and unable to do simple things like this to help women. It's not acceptable. It means those who are controlling us have a problem with priority. Now, most women with breast cancer, really, in the US, we get non-palpable abnormal imaging because we do mammograms. By the time most of my cancer patients I see, I told you I see an average of about 10 to 20 breast cancer patients a week because I see 25 patients a day. And in the 10 to 25 patients, breast cancer patients I see, 80% of them are stage 1. So 80% of them get cured. They don't really need to come back to me. They get cured really. And it's a good thing, it's a good feeling. And then we keep them in the system, we follow them up. If they have a reoccurrence, we pick it up, and that has improved mortality. If a woman already has a palpable painless mass, needs to see a doctor. Enlarged axillary lymph nodes need to see a doctor. And this is how we find most breast cancers, because screening is not priority. So to the general practitioners in the line, when you're seeing women, they are financially capable, order them to get a mammogram. Mammograms are becoming available in Cameroon. I think almost all the regional hospitals now have one. One was just installed in Bamenda and in the Southwest. So please do that. At times, less commonly, but more common in Cameroon, you have discharges, you have invasion of the nipple, you have skin changes, you have breast pain and all of that. So you have to take a good history and all of that. This is important. I think these are things that you guys do already. Now I'm coming to points of contention each time I go into my slides. Please, for the pathologists who are here and for the doctors who are here, please hold your pathologists responsible. If a pathology gives you a biopsy without the following characteristics, is inappropriate for breast. We need the histologic type, that is done commonly. We need the grade, that is done commonly. We need the estrogen progesterone receptor level. We need the HER2, immunohistochemistry, and FISH. Because now we have another classification, actually HER2 low, which I'm not going to talk about because we have treatment for it. It's a medical classification for medical oncology because we have a way of treating. We need the Ki-67 to decide on abemaciclib, but we may not have abemaciclib in Cameroon, but these are things that are the basics that have to be on the pathology report. You can take a picture of this, but it has to be on every breast pathology report. So now, not all patients with breast cancers do need systemic scans before you do take them for surgery. So, but I would always advise when you're testing and getting them here, radiologists do that for us. They do put a clip when they see a lesion. They're the ones who do most of the biopsy, and they're able to identify those areas. You have to get at least certain basic blood work, because if the alkaline phosphatase is elevated, most likely there is mets to the bones. If your AST and ALT are elevated, you want to do a scan of the liver. If a patient has lymph node involvement, you need a CT chest, abdomen, pelvis for staging. If a patient has a lump mass that has been there for months, you need staging workup, please. Don't take them to the OR. Do surgery, which is useless, and then bring them back. Most patients with stage 1 and up to stage 2B do not need imaging, general imaging, but you have to do it if you do blood work and you have an alkaline phosphatase elevated, you need a bone scan. If you do have liver enzymes that are elevated, you need a CT chest, abdomen, pelvis. If you have chest syndromes, please do that, because do a CT of the chest if they are short of breath. But everyone with stage 3, lymph node involvement, N1 disease, everyone lymph node lighting, please send them for a CT chest, abdomen, pelvis is appropriate. Don't go ahead and start doing a mastectomy without doing that, because if they have metastatic disease, clinical trials, I'm sorry everyone, have shown that the surgery is useless. There is no need for mastectomy, even if you want to do tumor debugging. This is not one of those cases. All the clinical trials were negative. Another thing which I will talk about to everyone is trying to define menopausal status before you start treatment on these women. Are they pre or post-menopausal? Especially in Cameroon, where we have a lot of young women having breast cancer. Please know their menopausal status, because it's going to help you in the adjuvant setting and deciding what to give in terms of hormonal treatment. So I'll do a little talk on ductal carcinoma in situ. What is ductal carcinoma in situ? Meaning that it's actually stage 0 breast cancer. You have malignant cells, but they are all within the membrane. They are not yet out. So these cases are actually treated. Every treatment of ductal carcinoma in situ resembles the same treatment we give for breast cancer. Just remember that. But they do not have breast cancer yet. They are stage 0. So this is the big question I always have: mastectomy versus breast conservation surgery. What should we do for these patients? In our setting in Cameroon, this is a terrible debate. Why? Because I would today advocate for mastectomy. I know everybody will look at me like being foolish, but the question is really this: how many patients can afford radiation? If you're doing a lumpectomy, you must do radiation. You can omit radiation in some few cases. Now, if you're unable to do radiation, that becomes a problem. So you have to access, if you want to do a lumpectomy, access the need for radiation and how to do radiation in your setting. So multiple studies, I will go through some of them, have shown you that in the past, it's not in my slides here, the NSABP 04 was a trial in the 1960s that showed us that Holstein mastectomy was similar to simple mastectomy. So we stopped doing radical mastectomies. Let me see if I have that in my slide somewhere. I'll go there. So we stopped doing radical mastectomies because of this. What we call radical mastectomy is taking away the breast, the pectoralis major and minor, taking out the lymph node. Don't do that. There is no benefit. This was 1960. Clinical trials came out and showed that there's no benefit. There is skin sparing mastectomy, and immediate reconstruction can be done if you have a plastic surgeon. Also, retrospective studies showed that that is good for women. Then the NSABP 06 in the 70s actually showed that total mastectomy was equivalent to lumpectomy plus radiation. So if you're doing a lumpectomy, you should be able to do radiation alongside with it. And the NSBP 18 did show us that chemotherapy before and after surgery is equivalent. But I'm going to come to that. So these are very important studies that we need to know about. If you're doing breast conservation surgery, you have to refer them to radiation. Now, what is a negative margin when you're doing DCIS? The strange thing about this is that for DCIS, you need a 2 millimeter negative margin. If your margins are positive, you have to go back. If you're doing a lumpectomy, go back for surgery. Radiation is not going to help you. That's how clinical trials show. So this is really one of those things. When during question and answer, I can talk about them. Now, are there patients that we can spare radiation if we do breast conserving surgery? We had more than 10 clinical trials. I just summarized them here. All patients benefited from radiation, those who have DCIS, all of them will have lumpectomy. But there are a few low-risk patients that we can avoid it in them, but that should be a call by the radiation doctor who is well-trained. I'm going to use that word, who is up to date. But generally, for principles to keep all lumpectomy patients need radiation. So here are some of those trials. This is the NSABP 24. As I told you, this was actually to evaluate NSABP is actually those who were not here, the National Surgical Adjuvant Breast and Bowel Project. Is most of the trials that were done in breast cancer in the US. So this was tamoxifen versus placebo, and it showed that giving tamoxifen to these women after getting either lumpectomy or mastectomy actually improved survival. So this is just part of the trial. Later on, we did trials comparing tamoxifen and anastrozole. In postmenopausal women, there was a benefit. Here is the little benefit in terms of breast cancer-free interval. So anastrozole, letrozole, and exemestane are better for postmenopausal women. But if they cannot tolerate it or they have a reason not to want it, you can still give them tamoxifen. For premenopausal, tamoxifen is where you go to. Or you do anastrozole plus ovarian suppression therapy. Ovarian suppression therapy is either taking out the ovaries surgically or by giving them medication to suppress the ovaries. So these are the data that I have here for mostly for the oncologists who want to look at it. Overall survival was also positive. I try to keep summary slides for take-home message. What is the take-home message behind a DCIS? The take-home message is that mastectomy or breast conservation surgery are equal, but you have to do radiation. If you're not doing radiation, they are not equal. For DCIS, and I've told you DCIS, you treat it exactly like how you're treating breast cancer, which is lookalike. Surgery should remove all microcalcification and obtain a negative margin. So we need our pathologists to be on top of this, and they should report this. And please, the surgeon should hold them accountable if they don't report this. Radiation after breast conservation surgery, for most patients, almost all patients benefit. There are a few of them that do not you can skip it, but most patients do benefit. Consider 5 years of tamoxifen or aromatase inhibitor. 5 years, not more than 5 years. That was in one of my questions. Now let's go to invasive breast cancer. Invasive breast cancer, I'm going to answer the same questions, which I always call them controversial questions, and I want to answer them today. Mastectomy versus breast conserving surgery. What should we do? It's the same like DCIS. Please, if you're doing a breast conservation surgery, the patient needs radiation. Post-mastectomy radiation, what type of radiation? Axillary lymph node evaluation. How should it be done? Should all women get axillary lymph node evaluation? The answer is yes, but we should not do, there should be centenary lymph node. We should not be doing dissection of axillary lymph node in this age and time, which we had stopped doing since the 1980s, please. So mastectomy. This is mastectomy versus breast conservation surgery. Up in my slide, that is Halstead. Halstead is actually the father of radical surgery. Radical hysterectomy, radical mastectomy. Radical actually did not mean radical itself, it's removing the cancer from its roots. That's really where it came from, the Latin word. So we no longer do this, what you see here. Please don't do this to women. Okay, don't do this to women. Here, don't do it to any woman. Do not. This is what we should be doing, simple mastectomy. Why? Because I told you clinical trials have shown that they were the same. If you're planning to do a breast conservation surgery, make sure you're well trained, you have good pathology that is going to tell you about negative margins, and you're able to do radiation. This is the famous John Hopkins surgery of the Halstedian policy. That's how it was called. We have to uproot all surgery from its roots. It was standard of care till 1970 and was proven to be the wrong thing to do for women. These women died the same with women who had simple mastectomy. These women had more comorbidities, and Halstead, being a wonderful surgeon who trained in New York, close to at Cornell, where I trained, it's similar, but this is not good for us all. So mastectomy versus breast conservation surgery. Breast conservation surgery requires adjuvant radiation all the time. If you're a surgeon here, please know that. You're doing it. There were 7 randomized trials. I'm not going to go into all the details, and it showed that local reoccurrence with breast conservation surgery no longer higher than that of mastectomy. But in Cameroon, because only one center is capable now of doing radiation adequately, I don't know how all these women will be able to get radiation. It's sad that we have to take their breasts out, but it may be a better solution for them. Now, there are some absolute contraindication to breast preservation surgery. I have the list here for those who are oncologists, but you should know that inflammatory breast cancers need mastectomy. They also need chemotherapy, no matter their ER and PR levels. And these are some of them, there are other patients here that will need that too. So the next thing I would want to do here is really just to summarize where we are coming from. Where we were in 1960s was called staked radical mastectomy. Where we are in the 2000s, options for women include reconstruction and breast conservative surgery. We need to be able to do sentinel lymph node biopsy for axillary staging and not just go and take out the axillary lymph node. Where we are going in 2023, which I'm not going to present those trials, for those who are interested, I love clinical trials. So if you've never known that, I really love them. If you want updates, I can always do that. They are moving to less surgeries, capacizing multiple. It's actually a multidisciplinary team. We even are trying to see if we can de-escalate surgery in some women because we're diagnosing them very early. Now for axillary lymph node evaluation, what is the standard of care? These are the complications that occur for those who have axillary lymph node biopsies that are not supposed to have it. You have lymphedema, you have shoulder dysfunction, you have paresthesias. And this whole thing became a whole problem, and we needed to do a lot of research. So this is where sentinel lymph node dissection comes in. I've already talked about this. This is something that needs us to reinforce capacities in our hospitals. In the general hospitals, the regional hospitals, we need to advocate for doctors to get training, be able to do this. It's a simple probe you use during OR. You are able to insert the dial and you can able to see which of the nodes is the first node. You take out that node. It's actually an axillary lymph node dissection. And if that node is positive, then you know that the nodes are involved and you can decide further what to do. We do use tracers, which are titanium tracers. You can also use injection of blue dye. And these are clinical trials showing that if you have one single modality, it's also good. We do double modality here, but single modality is something you can actually do, but it's better with double modality than single modality. These are the clinical trials that helped us establish this as standard of care. If a patient has clinical negative lymph nodes, please, these patients need an sentinel lymph node evaluation. You don't need to go in and do an axillary lymph node dissection in this patient. Clinical trials show that they were equal, and so we have stopped doing axillary lymph node dissection in those who have a negative clinical node. These are other trials that actually confirm this. So going forward, we know that if you have a positive lymph node, then you really need an axillary lymph node dissection in that case, because the trials do not cover that. So those are the patients who need an axillary lymph node dissection. But there are some trials that have actually looked at women, I'll go to that, who were positive lymph nodes, elderly women, postmenopausal, 1 or 2 lymph nodes which were positive. Do you need to do axillary lymph node dissection? The answer is no. But this is very detailed for the oncologist, but please, we should be able to understand this so that not all women get to increase the risk of lymphedema without any increase in survival. So these are some of the practical changes. Yes, caution for patients who do not meet the Z001 eligibility criteria, that's the trial. Clinical node positive patients, neoadjuvant chemotherapy patients, mastectomy patients, all these patients need an axillary lymph node dissection. So axillary lymph node dissection remains the standard of care for certain patients. But most of our patients, if we are screening, do not need an axillary lymph node dissection. For young patients who have early stage disease, these are patients who have sentinel lymph node was not able to be identified with a dye. Patients undergoing mastectomy with sentinel lymph node positivity need an axillary lymph node dissection. Patients with clinical plus lymph node going for upfront surgery. Patients with clinical plus lymph node positive disease need axillary lymph nodes dissection. Now, the last part before we end this section 1 is adjuvant breast radiation. Do everyone need adjuvant breast radiation? Those who carry out breast conservative surgery do need it. Clinical trials showed that. I told you more than 17 clinical trials showed that by doing radiation, you improve first reoccurrence, you improve cancer death, you improve survival. So all these women need it. That's just the take-home message. And there's some women where you can spare them radiation. Yes, they are, but as I told you before, you do need, this was a trial that was done in elderly women who are above 70 to see if we can spare them radiation. It was a negative trial, so even women who are above 70 need radiation. But there are some few cases that radiation oncologists can spare them. There is something else that we do call accelerated partial breast radiation, which we're trying to reduce the number of days these women come in, not for 6 weeks or 4 weeks. We want to do it for 2 weeks. And this is standard of care right now. It's not accepted by the NCCN guidelines, but the ASTRO guidelines actually accept this as part of the care that we can do. So post-mastectomy radiation, if you're taking out radiation, do you do radiation in those who have had a mastectomy? You do it for those who have positive lymph nodes. Okay, that's the only group of patients. You do it for those who have positive lymph nodes. These are the clinical trials showing you that those who have a positive lymph node need it. As a summary trial, as a summary slide, these are breast radiation principles. Whole breast radiation is standard of care. This is a summary slide. I want to take home message. Chest all radiation, including the breast and the reconstruction area, need to be radiated. Regional lymph node radiation added if the nodes are positive or if you have greater than 4 positive lymph nodes in women who are postmenopausal. So these are all things that we need to know in order to be able to help our patients and discuss treatment plans. So really, conclusion, local regional management for breast cancer. We have breast conservative surgery and mastectomy are equivalent for early stage breast cancer if radiation is done on the breast conservative surgery. What is breast conservative surgery? It's lumpectomy. So lumpectomy plus radiation equal mastectomy for early breast cancer. Breast conservation surgery is feasible for large primary tumors and local advanced breast cancer after preoperative systemic therapy. So you can do neoadjuvant therapy to reduce it, and then you give them breast conservative surgery. Sentinel lymph node biopsy is an alternative form for doing axillary lymph nodes with less side effects. And we have to get to the point where we are able to do that. Selected patients with positive sentinel lymph node can be omitted. I told you these are patients who are above 60, who have less than 3 lymph nodes that are positive. You can actually omit doing an axillary lymph node on them. So this is the first lecture. I'm going to get questions for 5 minutes. You can always unmute yourselves. Then we go to the second lecture. Here, the goal behind this lecture, I want to say it again. I want to acknowledge those who are in the town hall, my moderators, for making this possible. And I also want to thank the 52 people who are attending, and I think it's wonderful. And also acknowledge Dr. Francine, who is here. We've been working together. She's a medical oncologist at Bingo. She's doing a wonderful job there. So please, I would unmute, and these are the questions we talked about before. And I told you the first question, the answer was D. So breast implant does not increase the risk of breast cancer, please. These are the explanation. Breast conservation therapy is a proven alternative to mastectomy in the treatment of the following. So B is the answer here, localized early stage breast cancer. The other ones are contraindication that I did put in so that you guys can understand. The next, all of the following are true with respect to sentinel lymph node surgery, except for B. It is not associated with risk for lymphedema, so it is associated with risk for lymphedema. You can have lymphedema from that too. The last one is question 4, 45-year-old premenopausal woman with recently diagnosed breast cancer. And the question was, what do you give her? She's 45-year-old, she's premenopausal. From the lecture, I told you tamoxifen is the only thing you can give premenopausal women for breast preservation. And here the answer is C, discontinue endocrine therapy. After 5 years of patients who have had DCIS, you don't want to continue endocrine therapy. And here the answer is no. So before we move over to the next lecture, I know we've been talking a lot. The next lecture is going to be very interesting because it comes to medical oncology and something I like to talk about. So any questions, you can raise your hand and I would unmute yourself. I'll take some few questions. So this is going to be a 4-part series. Today, we're going to talk about local disease. Tomorrow, we'll talk about metastatic disease and special conditions. Those special conditions are like men with breast cancer, women who are pregnant with breast cancer. Those are all special conditions that we have some special things that we need to do for those particular groups of people. So tomorrow, we'll talk about that and metastatic disease. In metastatic disease breast, yes, there is the hand of, Dr. Francine, please, you can unmute yourself.
Okay. Thank you, Dr. Munoh. This is really, really helpful. And I just think that it is going to help us to change our practices. But also, I think that as long as cancer will be treated out of pocket, this is how it will be disorganized because, it is, if you see what is happening in Cameroon, you have a patient coming to you and the patient said that I have 100,000. You walk inside the 100,000. Sometimes it's so frustrating that you don't know what are you going to choose. So as long as we will not have maybe programs that are covered, or maybe we should just focus on screening, we can maybe focus on one thing and then we say, okay, we are good on screening. So that is going to help. But the majority, unfortunately, the majority of patients are coming late, advanced disease presenting with metastatic disease. We are not in a country where we have how they call it, a national guideline. Everybody does his own, So, the problem is really complex. So, what's my one thing that I want to emphasize here is about those who are even coming early. And we were talking about the ductal carcinoma institute, the patient that we need to do breast conserving therapy. But I've cried because some of the women, when they have that removed, they got missing. We don't know how to even trace the patient. So that is an important thing because when the patient is coming to you the first time, this is the time that we do our highest best. Once we lose them, they will come back to you with stage 4 disease. Because maybe they didn't understand the importance of going to Douala to do the radiotherapy. And even the radiotherapy, I think it has a timeline. Now, yes. the timeline. So now some of the patients have gone 2 or 3 times, they get discouraged. Please
unmute yourselves, please. Yes, Dr. Francine, please.
Yes, and they get discouraged. So then they could go back to the village. Then after 4 years, this is a patient that was ductal carcinoma institute. She's coming back with stage 4. What has really happened? You find that I went there 2 or 3 times, so they didn't get the appointment, or it was too busy. The waiting list was too much. So really, what is the modality that we in Cameroon should adopt? Because we can't do copy paste. It will not work.
Yeah, that is a wonderful discussion, and we have had that. And that's what I said. Sadly, in the Cameroon setting right now, I think screening, I'll go to the first part of your intervention. Screening should be where the government should put an effort. Why? Because that's where they can make a huge difference in terms of mortality, in terms of prevention, and in terms of even curing patients with early disease. I think that's where we should have a national strategy, adopt WHO recommendations, start screening from the age 50 and every 2 years, and screen girls who have family history of breast cancer with anyone who has had breast cancer at an earlier age, you screen them 10 years prior to the person who had breast cancer at that age. That will be where we'll make a big, big impact. The second part, as you said, is a practical problem in Cameroon. We said we have just one radiation oncology machine functioning, and it's private and it's expensive. And think about a patient who is living in Twerere, who is living in Yoka, who is living in where? In Womb, who is living in even in Com, in Ashin, who has to go to Douala for radiation. It's almost a very life-changing decision. So I am also one of those, Dr. Francine, and you know we have had this discussion, who advocates for mastectomy, because we are just, especially for early stage patients, it can sound brutal, but we are just unable to give these women appropriate treatment, and most of the time they will reoccur. And sadly, I'm saying this, I've reviewed many pathology specimens. The techniques, maybe what they have in their disposal, they are unable to even tell us if it was triple negative or what it was. So we don't even know the level of aggressiveness. And then two, we don't even know if the margins were negative for those who have been doing lumpectomy, and those who are doing lumpectomy were not professionally trained, most of them, for that, because they were not well supervised. So this becomes a big issue with reoccurrence because we have residual disease. So I really support what you're saying, but both of us may look barbaric by saying that these women need mastectomy just because lumpectomy without radiation is not equal to mastectomy. Sadly, it's not. So are there any interventions? If not, we'll go over to the second lecture and we'll have 2 hours for this, 1 hour for discussion. It's going to be a 3-hour session. So let me share my screen for the second part of this discussion, which is the part I love so much. But my best part is actually metastatic disease. So it's not that I'm mean, please. So it's just that that's what I do a lot. I'm a medical oncologist. Now, we're going to talk about the second part, which is systemic therapy for primary breast cancer. Why was this labeled systemic therapy for primary breast cancer? A lot of people ask me a question, oh, why did you organize it this way and all of that? The reason is that that is how we treat, that's how we train our residents and fellows on how to look at breast cancer. Every patient with breast cancer needs systemic therapy, every one of them. The question is what type? This is not metastatic disease. These are patients with stage 1 to stage 3. So this model, we're going to talk about systemic therapy of primary breast cancer. And still, I'm going to give my disclosure. This has nothing to do with my employer, who is the Presbyterian Hospital. So this is purely facts that I get from the national guidelines based on clinical trials, and also these are facts that have been published. I always start I'm sorry guys, you have to go through questions, okay? So we have here, you are treating a 46-year-old woman who presented with left breast mass. Note that. We did a core biopsy. As I said, we should not be doing fine needle aspiration. That disclosed poorly differentiated invasive ductal carcinoma. Luckily, they did an ER, which was negative, a PR, which was negative, and a HER2, which is negative. So she's triple negative. If you have the least amount of money in Cameroon, you do a biopsy, please send me a immunohistochemistry. That's more logical priority. You are doing the patient the best decision ever. Don't go for surgery, send this. Her tumor measures 3 millimeters and she has at least 1 involved axillary lymph node, so she's a stage 3. Which of the following statement is true? This is now real medical oncology. I'm sorry, guys. We can give 6 cycles of docetaxel plus cyclophosphamide. Is equivalent to an anthracycline and taxane regimen in triple negative breast cancer. This is false. I'm going to help you guys, okay? The next one is chemotherapy given neoadjuvantly rather than adjuvantly results in better relapse-free survival. This is false. Actually, the NSABP 18 trials actually showed that You could do chemotherapy before or after their equivalent, but there is an advantage of doing chemotherapy before, which that's the practice we do now. And the advantage is that you turn to be able to know those who have complete response. You can adopt treatment after, you can give them further treatment. So there is really an advantage in triple negative patients to get chemotherapy neoadjuvantly. For those who don't know, neoadjuvant means any neoadjuvant intervention is intervention before the primary treatment modality, before surgery. Then carboplatin added to AC and taxane-based neoadjuvant chemotherapy does not improve pathological response to therapy. That's false. It does improve. So by adding carboplatin, you increase toxicity, but you improve response. This is very technical, but this is where I want you guys to know the standard of care right now is the addition of immunotherapy called pembrolizumab to anthracycline and taxane-based chemotherapy improve overall survival and event-free survival for those who have triple negative breast cancer greater than stage 1. This leads me to a sad reality that we have had immunotherapy for more than 20 years, but they are still not available in a lot of African countries, including Cameroon. So let's see, sorry. The next question, so this is the right answer. The next question before we go ahead is, you are treating a 46-year-old premenopausal woman who has undergone lumpectomy for a 1.2 centimeter grade 1 centenary node negative breast cancer. That is ER/PR positive and HER2 negative. Her oncotype reoccurrence score is 10. So this becomes very tricky. I'm using these questions to bring up a problem. Here in the US, when we have a woman like this who is premenopausal, we do something, and who has HER2 and who has ER and PR positive breast cancer, except in all countries in Europe. And even in Ghana, I just got a patient who was in Ghana. A friend sent me a patient who was in Ghana. They got all this done initially, and I was very pleased. The question becomes, does this patient need chemotherapy or not? The oncotype is something we'll talk about today. I will lay a lot of emphasis just on the oncotype, not the mammo print. Tells you if a patient is going to benefit from chemotherapy or not. An oncotype of 10 means the patient will not benefit. Any premenopausal patient who has an oncotype less than 15 is not going to benefit. Any postmenopausal woman who has an oncotype less than 25 is not going to benefit from chemotherapy. So giving them chemotherapy is useless, and majority of women will fall under that category. So the question was, what do we treat? How do we treat this woman? She's premenopausal, so the options here will be tamoxifen. So the next question to setting out the pace is, you are seeing a 52-year-old woman with a T2N1 ER negative HER2 positive breast cancer. So she has HER2 positive disease. If you have seen, the general message is that I cannot treat breast cancer without knowing these markers. That's why I say if there's one thing you have to do, please, let's stop behaving like we're in 1960. The woman has 100,000. Tell them that these markers are going to change everything. The long-term cost, you may end up giving her 20 rounds of chemotherapy when she does not need it. It's going to change everything. By doing this, 100,000 now would save millions later. And that should be the practice that I want to instill in everyone. She has finished 6 cycles of chemotherapy with TCHP. TCHP is docetaxel, carboplatin, trastuzumab, and pertuzumab. Because she's HER2 positive, we gave her that, and she has node positive disease and has undergone mastectomy and axillary lymph node dissection. The pathology reports that the tumor bed shows treatment effectiveness and there is 10% viable tissue, so she still has positive tissue there. What do we do? This is purely an oncology question, but it's good to help the oncologists here too. You want to escalate care. In this case, we need to give an antibody drug conjugate, which is called trastuzumab extensin. There are clinical trials going on which trastuzumab extensin is going to be replaced by trastuzumab deruxtecan. And these are all things that are going on. We'll talk about this tomorrow, but this is what you want to do. So I'm going to talk about some principles, try to make it easy for those who are non-oncologists, but who are medical doctors and who are going to be seeing our patients to know exactly what we do. So the general principles, we'll talk about them, and it's going to be one slide, and that's going to be one of the most important slides. Chemotherapy and immunotherapy is now standard of care for triple-negative breast cancer for those who have localized disease, because here we're not talking about metastatic disease. Chemotherapy and anti-HER2 therapy for those who have HER2-positive disease. And this is why it's important. I know Herceptin, which is trastuzumab, is super expensive. This is where we are calling on the government. We cannot have a drug which has been existing for more than 30 years, and for it to cost patients millions to get it when there are generic forms of it. So if the government gets serious, these are things that have to be added. This is advocacy, those who are here, added to the national guideline essential medication list. Pertuzumab may not need to be added, but trastuzumab needs to be added. Hormone receptor positive and breast cancer, we'll talk about those who need chemotherapy in the early stage and who need endocrine therapy. Because we are not even doing the basic things, I will not lay emphasis on the PARP inhibitors, which are more of those who have BRCA genes. So what is the general principle? The general principle for systemic disease is that it's given to improve survival by treatment of micrometastatic disease. We learned this from Halstek's radical mastectomy. When Halstek did radical mastectomy, he got frustrated because each time he came back, there was a small lesion in another place popping up. So micrometastatic disease cannot be surgically removed. And that is why we do adjuvant and neoadjuvant treatments in order to take care of micrometastatic disease. We can do hormonal treatment, we can do surgical, we can do chemotherapy, we can do immunotherapy, we can do targeted therapy. In breast, we'll talk about what we do. The benefits depend on both the baseline risk of reoccurrence and the effectiveness of the therapy based on what we know about this patient. We need to consider the comorbidity, the side effects, and the preferences. I'll tell you this without really revealing what I do. I've had patients who have come to my office, 90 years old, has breast cancer, and she tells me, doctor, I do not want chemotherapy. I want only surgery. I don't want radiation. So every patient needs to be balanced based on their longevity, how long they are going to live. Are they going to die from this breast cancer? So she got surgery, and I convinced her she came back estrogen and progesterone positive. Her oncotype score was 35. She needs chemotherapy, but I do not want to give her chemotherapy to a 90-year-old. I'm going to kill her. Cancer is driven primarily by hormonal treatment. So she just needs hormonal therapy and she gets out of my office. Full stop. So you need to adopt these treatments based on the patients who are in front of you. Now, these are from the Oxford Review. The UK did wonderful studies on breast cancer back in the 60s, 70s, and 80s. The Oxford Review looked at the benefit of chemotherapy throughout multiple clinical trials for patients, and we saw that after surgery, chemotherapy benefited patients who got chemo, but this was mostly those who were HER2 positive and those who were triple negative. There is even a larger benefit when you do hormonal therapy. Larger benefit, and this was not even stratified to those who were hormone positive. But by giving tamoxifen, this was just analysis for tamoxifen, which is the oldest SERB we have had, we saw huge benefit, reduction of mortality by almost 50%. And this is why we do what we do after surgery. So those who are surgeons, surgery never cures cancer 100%, please. There's some humility. Surgeons need to learn about this and understand it. Halstek learned this early, and so we need to be able to understand that it's not how radical the surgery is that you're going to improve the patient's outcome. It's not by doing extremely radical surgeries that you're going to improve the patient's outcome. Now, what are the things that are important for all patients with localized disease? You should get a diagnosis through a core biopsy. I've told you guys, I'll keep insisting on this. I don't want to get you guys in Cameroon doing fine needle aspirations anymore. Core biopsy, because I want you to send the ER, PR, and HER2 levels. If the patient has 100,000, that's what you should send. Nothing else, send that and then wait. If you're too anxious, know that 80% of breast cancers are HER2 positive. Start them on estrogen and progesterone positive. Start them on anti-progesterone medication, and start them on tamoxifen or anastrozole, depending on their age, and you will not do wrong. Don't confuse intraductal carcinoma with... Please, okay, someone, let me unmute this. So don't confuse DCIS with invasive ductal carcinoma. The reason is because if you do a fine needle aspiration, you're going to confuse that. With a fine needle aspiration, you do cytology, you don't do histology, and the cytologist will not be able to differentiate DCIS from cancer. Invasive lobular carcinomas are always, almost always 99%. If someone gives you cancer and says it's not ductal, it's lobular, it's estrogen and progesterone positive until proven otherwise. If I have a pathology, I've had it throughout my practice and the practice of my mentors who trained me. I have a mentor who told me he has seen it only twice. And he has been treating where I trained. You have people who are specialized just in breast oncology. They just do only breast. I do general oncology. They see hundreds of patients, but he told me he has seen this twice. So any lobular carcinoma is actually ER/PR positive. You may not even need to stain it, but you need to do that to know the HER2 level. Don't do systemic staging studies for stage 1 patients unless they have symptoms, and you have to document that in your notes. To me, this is one of the, I've been sending this to a lot of people. This is one of the most important slides I have. Why? It tells you exactly how we do divide breast cancer. Data from Nigeria, from Ghana, there's no data in Cameroon, has shown that in Africa is the same thing, similar. Only about 15 to 20% of our breast cancers are triple negative. All triple negative breast cancers need chemotherapy. But you realize that 80% of our breast cancers are ER/PR positive. They are hormone positive. They are driven by hormones, and hormonal treatment is cheap. So please do it. Don't get these women spend millions when you would have done this and spare them from chemotherapy in certain situations, especially in metastatic disease. The truth about it is that if a woman cannot afford chemotherapy, maybe you're unable to do an oncotype, just give them endocrine treatment. It's going to do the same, going to do a good job. It may not do the appropriate job. She may be young. She may have a high oncotype. If her lymph node is positive, she needs chemotherapy. So this is so important that this is one of the pictures I want people to keep in their minds. Engrave it, that 80% of all your breast cancer is estrogen and progesterone positive. That's what is driving this cancer. And hormonal treatment is the standard of care. How do we treat patients with breast cancer? Look at this chart. I've made it. This is just a schematic review that all the general practitioners should take home. If a patient is HER2 positive and hormone positive, this first quadrant here, anyone who is HER2 positive needs chemotherapy. That's just the bottom line. That's why you need to do it. They need chemotherapy, they need anti-HER2, and they need endocrine therapy because they are also hormone positive, and you need to sequence it. Sequencing it is going to be a whole discussion in oncology that you leave it for the oncologist, okay? You send them to Dr. Francine and you stay quiet, but you do this first. The next one is those who are hormone positive and HER2 negative. The main treatment is endocrine therapy. It is nothing else, endocrine therapy plus or minus chemotherapy. Endocrine therapy in Cameroon is cheap. I had a patient, it's not my patient, but it's my mom's friend's daughter who died in Cameroon. 2 days after she died, they had called me a month before, and I called them to send the specimen to Centre Pasteur. This baby girl had breast cancer multiple sessions of, had a mastectomy, first of all, double mastectomy 2 weeks after they realized that she had long meds already. So she had those meds before the mastectomy, which was useless, and spent much time in the hospital recovering. This is really a case that summarizes the problems we have. Then, even with the mastectomy spacement, nobody did any hormonal treatment. She got chemotherapy in Yaoundé, multiple rounds of chemotherapy, could not even tolerate it in l'Hôpital Général. Finally, when the hormonal receptors came back 2 days after she died, she was estrogen 100%, progesterone 100%. I wept for her because I realized how you could feel. The family felt they did all for her. But truly, this is a legal case. And in Cameroon, we'll start getting sued. This is a legal case. This young girl had to be alive and doing well. If someone had given her just amoxicillin, she should not die like this. So, any questions? Now, if there are no questions, I know this is a bit very emotional. I said this because this case really is one of the cases that made me to realize that I have to do something. I don't have to only sit here and not do something. And I think the best thing I can do is educate the people back home. I see Erwan's hand is up. Erwan, you can unmute yourself. One question, then we'll continue. Erwan,
okay, thank you.
He's a surgeon, and I'm happy he's here.
Thank you, Dr. Munoh. It's really a nice, very important, and very useful presentation. The question I want to ask you is that when it comes to chemotherapy, knowing that in your country, for example, the life expectancy is, let's say, maybe 80 among maybe white women, but here our life expectancy is rarely more than 65. Even in some particular populations, like maybe the people who are wealthy. So when you have a patient who is more than 75, and then the chemotherapy seems to be the good thing to do we really have to go for the chemotherapy, even though technically, anyway, I don't know. What do you think about it?
Okay, so I'll answer your question and I'll continue. As I said, the gold standard is for you to tell me what the estrogen, the progesterone, and the HER2 levels are. If you can tell me that, that's the first step. Tell me what the numbers are. If the patient is frail, above 75, has a positive progesterone and estrogen, why are you giving chemotherapy to that patient? Stop. Unless the patient has visceral disease, which is very rare in breast cancer. Unless the patient has inflammatory breast cancer, even then I will not, in a frail patient, I will not do chemotherapy, especially in your setting where neutropenia becomes the highest cause of death. Most people die from the complications of that. So if it's breast cancer, I want to know the estrogen, progesterone, and HER2. If the patient has the last money left with him, do that. Don't start chemo. You will save him better. You will save their life. They will live a longer life by doing that. Chemotherapy is hardly an emergency here. So I'll tell you guys a story. Even in the US, I do not give chemotherapy inpatient, except for like 5 conditions. Patients with AML, acute myelocytic leukemia, ALL, patients with small cell lung cancer, patients with diffuse/B cell lymphoma and Burkitt's. I do not give chemotherapy inpatient. Why should I give it inpatient? It's not going to make a difference. So calm down. Chemotherapy is never an emergency, okay? Never, except in those situations. Or a patient who has a superior vena cava syndrome, you want to even do radiation. Chemotherapy is never an emergency. Never. Take your time and understand what is going on. Most of the time, other specialists need to help you. Critical care doctors, the patient is short of breath in the ICU, they need to stabilize the patient. You kill the patient. Most of the time, you need 3 rounds of chemotherapy to discover a difference. Now, triple negative breast cancer, I'm going to talk about it. I'll try to summarize as much as possible. It's the most aggressive. So for triple negative breast cancer, higher risk of reoccurrence occurs with patients with triple negative breast cancer. Chemotherapy is generally given pre-operatively for those who have local disease, because here we're still dealing with local disease today. Anthracycline and taxane-based chemotherapy is the standard of care. For women who have had breast cancer, they will tell you about anthracycline. It's what they call the red devil, okay? They hate it. Possible role of carboplatin has been established right now, and immunotherapy. For every patient who has greater than stage 2 disease needs immunotherapy. The role of capecitabine is for those who have neoadjuvant treatment and has residual disease, meaning that after you give them chemotherapy, take them to surgery, then your pathology is still positive, you can place them on capecitabine. I'm not going to insist on multiple trials. I have them here, but I would go fast. Preoperative therapy for triple-negative breast cancer has been shown to help us reduce improve pathological complete response. It doesn't improve mortality, increase the rate of breast conservation. Women who come in, you can actually conserve their breast, and you can have prognostic values in order to decide treatment after. If you do neoadjuvant simply means before they get surgery, you do chemotherapy. So these are trials just showing you that patients with triple negative need anthracycline. This is the most important. Someone asked me the other day, who was a physician, because I published something, he said, what is keynote? Was it that is a keynote speech or all of that? So there is a drug we call Keytruda, which is called pembrolizumab, which all the clinical trials on Pembro are actually named keynote. So keynote simply means they used Pembro. So it's keynote 522 is one of the name of the trial. This trial established immunotherapy as a standard of care for patients with triple negative breast cancer who have a positive limb, anyone with stage 2 and above. But I know that immunotherapy is not available in Cameroon. I know that it's millions of dollars. So we're still not able to do this, which is sad, but we can do other things. So this is the standard of care right now for those who have triple negative breast cancer. Chemotherapy and immunotherapy add a carboplatin-based chemotherapy to their treatment. And you can see here there was actually improvement in event-free survival. Now, the CREATE-X trial was done before this immunotherapy. It states that if someone has a triple negative breast cancer, I think by now you guys see the message. The message is that I cannot treat breast cancer if I don't know the patient's hormonal status. That's why I'm classifying it into triple negative. For triple negative, what do? You give them hormonal treatment, then you do surgery. After surgery, you evaluate if they still have residual disease, you give them more hormonal treatment. So you can give them capecitabine. This is trial showing the importance of giving them capecitabine. So this is my summary trial, my summary slide, which is what you should take home for triple negative. If a patient is stage 1 triple negative breast cancer, meaning that their N0 and their size is less than 5 centimeters, you can actually do neoadjuvant anthracycline therapy. You don't need immunotherapy. If they have residual disease, you give them another chemotherapy called capecitabine. For anyone with stage 2 and 3, they need immunotherapy. The questions we have here, there are still some questions which are more questions for those who want to philosophize and oncologists. What do you do with capecitabine if they have residual disease, where you're going to give them Keytruda? What do you do if they are BRCA positive, which they may benefit from olaparib and all of that? Now for HER2 positive breast cancer, the same principles work. I told you all HER2 positive breast cancers need chemotherapy and HER2 directed therapy. This is a summary slide you need to understand. The first thing is that 5 to 15% of all breast cancers are HER2 positive. That's why you must do it. If you see this slide, I'm not treating triple negative patients the same way I'm treating HER2 patients. They are different. HER2 positive breast cancer is anyone who has an IHC of 3 or more. If they have an IHC of 2, you need to do a FISH to identify it. And this is an advocacy that has to be done in Cameroon. The gold standard depends on the stage. If the patient has a T1N0, no lymph node involvement, a stage 1 disease, you could go ahead and do surgery up front, and you give them HER2-directed therapy and chemotherapy after. You can just do docetaxel or paclitaxel with trastuzumab. Any other stage, the patient is going to need chemotherapy and 2 anti-HER2-directed therapy. But in Cameroon, it's so expensive to even get Herceptin, not to talk about pertuzumab. So I would advocate for Herceptin to be included. And if patients have residual disease, then you can actually give them a drug conjugate called trastuzumab emtansine. These are the trials. I will not lay emphasis on them based on time. It's just to tell you that all what I'm telling you is based on clinical trials. This is the NSABP 31 that showed that adding Herceptin was important in women who had breast cancer. This is another trial that proved the same thing. So the initiation of Herceptin actually reduced mortality. This is another trial called the Affinity trial that showed that adding pertuzumab also helped to improve mortality, but the effectiveness of adding pertuzumab is not too high. So I will not insist in Cameroon that we give 2 anti-HER2s, which could be very expensive. So this could be super expensive for these patients. So in this situation, you see, by adding pertuzumab, you improve mortality, but not as much as Herceptin. This is another trial where they used a drug called niratinib. It's a TKI. We no longer use this because there are multiple other drugs, so I'll not lay emphasis on this. This is very important. This is where we need to know the drugs that are available in Cameroon and how we can help women. We said 20% of women have HER2-directed disease. If you give them chemotherapy and after surgery, their pathology is positive, then you have to escalate care by giving them something called TDM1. And I know TDM1 is not available in Cameroon. So what do we do with these patients? It becomes difficult on what to do. We're going to place them back on Herceptin and pertuzumab and trastuzumab and continue with the treatment. But here you can see that the Catherine trial really showed improvement. And that is what those who are in Europe, those who are in America, those who are in Asia are benefiting. Why can we not benefit from things like this? Breast cancer is not an easy thing to see. You can't just sit in the morning and think that you know breast cancer. So there is de-escalation trials when we have tried to see if we can give people little amount of treatment, but we can only do that in patients who have stage 1 disease, and the trials actually prove that. So I'm going to my summary. My summary, HER2 breast cancer. If there is anyone here who wants, this is a picture you should take. Everyone needs HER2 staining. If you have stage 1, you can get surgery upfront, and then after surgery, depending on the pathological stage, you can get HER2-directed therapy or nothing. If you have stage 2 disease, stage 3, this is really what you need to do. I would answer questions based on that. Now let's go to the most common type of breast cancer. Most common type of breast cancer is hormone-positive breast cancer, making 80% of them. The question here is, do all patients need chemotherapy? The answer is a big no. And this is practice that I really want us to stop. Do all patients need chemotherapy? No. And this is 80% of all our breast cancer patients. In the metastatic setting, it's even worse. They do not need chemotherapy unless they have inflammatory breast cancer or they have a visceral crisis, which is very rare. In the adjuvant setting, not all of them need chemotherapy. Most of them, I would argue, do not need it. But I know it's difficult for us to get an oncotype score. This is something we need to advocate so it gets done. If you have an oncotype score, which is greater than 25, you need chemotherapy. An oncotype is actually a genetic analysis of the cancer, which is estrogen and progesterone positive. And we had clinical trials that were done called the TELOR-X trials and the X-Ponder trials. In Europe, they use a lot of the mammoprint, which is the MINDAT trial that was done. These two things are similar. When to consider genomic testing. is node-negative patients, those who have a negative lymph node. Postmenopausal women, which is majority of women with breast cancer are postmenopausal, who have 1 to 3 lymph nodes may not even need chemotherapy. When to proceed with chemotherapy is premenopause. Anyone who is premenopausal and has a lymph node that is positive needs chemotherapy. Anyone who has postmenopausal disease with 4 lymph nodes needs chemotherapy. So these are just the trials which I have in my slides. I'm not going to insist on them, but I would say something here. In the TELOR-X trial, what we did was, or what the oncologist did was, anyone who had an oncotype less than 10 did not get chemotherapy at all. They just gave them hormonal treatment. Anyone who had an oncotype greater than 25 got chemotherapy, and they randomized those who were between 11 and 25 to see if chemotherapy was going to help them. For those who were less than 10, and it was a huge majority of the patients, they had 99.3% survival rate on endocrine therapy. You don't need to give them chemotherapy, please. This is for those who have local disease. This is not for advanced therapy. And even for advanced patients with advanced metastatic disease who are estrogen and progesterone positive, HER2 negative, do not need chemotherapy. So those who were 11 to 25 did not also benefit, but they did a subgroup analysis. And in the subgroup analysis, they found out that women who were younger than 45 years old and who were premenopausal. So this is how you treat women who have 80% of the kind of breast cancer you're going to be treated. It's HER2 negative, estrogen and progesterone positive. If they are young, premenopausal, and they have an oncotype score of 0 to 15, you give them only endocrine treatment. You're done. I find a lot of them get chemotherapy just because we're also unable to do the recurrence score in Cameroon. But if there is a treatment you want to choose for this patient, choose endocrine treatment. If they are poor, they don't have money, you will do them good. Chemotherapy will have no benefit in a lot of them. If their recurrence score is between 16 and 25, they need chemotherapy plus endocrine therapy. Or you do an ovarectomy, or you give them ovarian suppression therapy if they have already had their children, plus endocrine therapy. It's good enough. If their oncotype is greater than 25 and they are premenopausal, they all need chemotherapy. For women who are postmenopausal, majority of them, the oncotype, 80% of the oncotype will be between 0 to 25. That has been my experience in the US. They do not need chemotherapy. Those who are above 25, last week I had the highest oncotype I've ever seen, 100. I was 110. I've never seen that before, but they do need chemotherapy. What about node positive, ER positive patients? This was a clinical trial, the same thing. Not everyone with a positive lymph node even needs chemotherapy, okay? If you have less than 3 positive lymph nodes and you are postmenopausal, you do not need chemotherapy. That's what this trial showed. Now, there is another question. So my conclusion here is that in a resource-poor country where we are unable to do an oncotype, we have patients who have localized disease, which is ER/PR positive. Which is more important? Is it the chemotherapy or the endocrine therapy? I would hope all of you will know by now that is the endocrine therapy. And if you can omit the chemotherapy because of financial reasons, do it, please. It's just adapting medicine to the right context. Their cancer is driven by endocrine therapy, especially if their ER/PR levels are greater than 10%, please. Do not go into the habit of reading guidelines and not understanding them. I see that kind of practice go on a lot. Now, which chemotherapy is better? I'm not going to go into this debate because the best chemotherapy cannot be given in Cameroon. We need dose dense AC, which is an anthracycline with paclitaxel, but you're going to need support. When you're doing dose dense chemotherapy, you need support for the blood count. So you need to give them Neupogen, you need to give them Granex, you need to support them growth factor stimulating agents. And that's why most of these patients do die, even because we kill them with chemotherapy. We're actually responsible for killing a lot of them. So the role of CDK4 inhibitors, we'll talk about this tomorrow more. What are CDK4 inhibitors? They are new drugs that we use in the metastatic setting in combination with hormonal treatment and a standard of care for patients who have ER/PR positive breast cancer, which is 80% of all breast cancer. They don't need chemotherapy. They need hormonal therapy and CDK4 inhibitors, full stop. Knowledge is power. And I think if the general practitioners start questioning those who are around them, who are practicing this kind of practice, things will change. That is why my emphasis is to educate those who are in medical school. I'm very sad that a lot of times they don't come into lectures like this. They want to rely. The world has changed so much that you can get information anywhere. You don't need to be in an amphitheater to get information. And they would actually help to build our healthcare system. Now, abemaciclib is what you can add in some of these women who are high risk and who are hormone positive, and is FDA approved. So what is my take-home message? This is the slide that is kind of a take-home message slides that I'm going to give you guys to have. Adjuvant endocrine therapy. Hormone receptor is considered positive when you have ER/PR greater than 1%. This just changed. It used to be 10%. Anyone with 1% is ER/PR positive. That's why 80% of breast cancers are ER/PR positive. Menopause status is very important in diagnosis. Never start treating a woman with breast cancer without documenting in their notes if they are menopausal or not. It changes treatment. Duration of giving endocrine treatment should be at least 5 years. For low-risk women, for high risk, you can do 7 to 10 years. This is a big debate. There are trials that I will not go into the details because it's a lot of debate. Also depends on their tolerance. Now, for premenopausal women, women who are still seeing their menopause, if you don't have anything, give them tamoxifen and you're done. If you really want to help them, and they have money, you can do ovarian suppression. What is ovarian suppression? Ovarian suppression is by suppressing the ovaries by using grezoreline or using Lupron or Luprolite to suppress it, or you can do surgery if they have had their number of children and take out the ovaries, and then you can give them an aromatase inhibitor. For postmenopausal women, you do tamoxifen and you can do an aromatase inhibitor. There are 3 of them. They are called triplets. They are all the same. You can do anastrozole, lestrozole, or exemestane. They are found in Cameroon. They are cheap. They are affordable. They are not very cheap, but they are more affordable than chemotherapy. For tamoxifen, those who are giving tamoxifen, you should know that tamoxifen increases the risk of uterine cancer, especially in those who are above 50. Monitor them for pulmonary embolism and DVTs, hot flushes, cataracts. They need to see an ophthalmologist once a year, and the menstrual irregularities. This is just the trial showing you that tamoxifen reduces mortality. ER/PR positive breast cancers do not necessarily need to have chemotherapy. This is the switching trial. Also, exemestane plus ovarian suppression, that is AIs, are better than tamoxifen. So each time I can give something other than tamoxifen, I do. This was some trial called the SOFT trial. All these trials actually showed, in summary, aromatase inhibitors work in postmenopausal women. You don't need anything. Anastrozole, lestrozole, and exemestane are equal. They are triplets, have the same mother. Side effects of these ones include muscle and joint pains. You need to tell the women. Vagina dryness, and they feel like they are getting their menopause all over, bone pain, and hot flushes. Do not give premenopausal women without ovarian suppression anastrozole, lestrozole, and exemestane. Please do not do that. So here is the duration. This is the switch model. There is nothing here. Here is the NCCN guidelines, which we use in the US. It can sound overwhelming, but it's not. So with PARP inhibitors is another thing we do. Those who have BRCA1 germline mutation, I told you some patients have genetic cancers. We can also add a drug called olaparib, talizoparib, to their treatment. and it helps improve their overall survival. So we know that. So in summary, by ending the day, and we'll go to questions, answers. We have 30 minutes to 1 hour where I can answer some questions. You can unmute yourself. The question is going to be, cancer care is a multidisciplinary team. Breast cancer is the most common cancer in Cameroon. Our mothers, sisters, and aunties are dying, and daughters are dying from breast cancer. We need to prioritize it. Hormonal treatment is the standard of care for those who have estrogen and progesterone positive breast cancer. Surgery is a modality, but please do not do surgery for those who don't need surgery. If a patient has metastatic disease, they do not need surgery. Bone marrow transplant is not a treatment for breast cancer. There was a time which trials were done. There was a fake study that was published. But bone supportive medications are important. Things like denosumab and things like all the different bone protection medications can help patients. Zoledronic acid and all of that, alendronate. For metastatic disease, we'll talk about that tomorrow. Not all breast cancer patients need chemotherapy. Send them to an oncologist that you trust and get the ER, PR, and HER2 status. Targeted therapy is becoming part of our treatment guidelines. Radiation is always needed for those who have a lumpectomy. Immunotherapy is the standard of care now for those who have localized disease, who have triple negative. We should advocate to get this back in Cameroon. And as I said, this is a book which I would advocate everyone to go get it, read it. It's a nice book for those who are interested in oncology. So I will stop here, and then I think we said presentations will have to be less than 2 hours. We'll take, these are the questions I asked in the beginning, okay? So I'm going to stop sharing my slides, and we can talk about take-home message. Please, you can always raise your hand if you want to talk, and let's get to discussing this topic. So any questions, please? You can unmute yourself. I see the hand, yeah, so Tumsi, Tondu, please, you can unmute yourself.
Hi, good evening, and thank you very much for this amazing presentation. I'm Tumsi Tondu, I'm a clinical and radio.
Oh, please, yeah, okay. You got muted sometime, I don't know. I'm hearing you. Yeah.
Okay, my comment and also question for you to comment on is about the use of online calculators for determining the need for adjuvant chemotherapy in patients with hormone receptor positive breast cancer. In the event that you don't have genomic analysis like the Oncotype DX or the Mama Print. Here in South Africa, we use things like the NHS Predict score to determine the need for adjuvant chemotherapy. I'm not any experience or any comments about that.
Yes, that used to be the standard of care. Those were research that were done in Yale and multiple other places. So thank you for bringing that up. In the developing world, that is an option, which can be very, very helpful in determining if a patient is going to need chemotherapy or not. But the clinical trials showed that their sensitivity and specificity is very, very bad when compared to the Oncotype. Because we don't even have an Oncotype, that is one of the ways to go forward. So I totally agree with you. Those are all tools that can be very helpful in our setting in order to prioritize patients that you will want to give chemotherapy to. But there is something I always say, and especially in Cameroon. In Cameroon, we even have more rudimentary problems that you cannot believe. We have problems where we are even unable in 90% of patients to get the ER and PR status. 90% of patients, we are unable to get the ER and PR status. So that becomes a big problem in the first place. So if we were able to get that in the first place, then by using online calculators, it's a wonderful tool that we have handy. Most developed countries no longer use it, but it's something you can use, and you can really make decisions on that. And there are other scores that we do use for risk stratification similar to that, just to stratify patients who have high risk lesions that can transform into cancer. We also use risk predicting scores even in radiation to determine patients who may need some, or we can omit radiation from, but most patients really do have a lumpectomy need radiation. And you're in the field of radiation. So yeah, so for hormonal treatment and chemotherapy, that's a tool which we can always get. And the availability of online, access to online internet is very high in Cameroon. So I don't see why we cannot use that. So thank you for that contribution. Yes, Sydney, please.
Yes, hi, Munoh. This is Sydney Taze, oncology physicist from the US. Thank you for the brilliant talk. Yeah, just a couple of comments. I'm also a big proponent. You mentioned the fact that mastectomy should be something that we should push a lot more in Cameroon, because I believe that whatever tools you have in your setting, that's what you should focus on. And we know that mastectomy gives the patients a very good chance of survival. That's the first point. And then also the question about online calculators. Yes, there are a lot of calculators that are well vetted. Well, okay, whether it's through Mayo Clinic or it's through MD Anderson. Usually when you use a calculator, make sure you're using something that was used in some of these clinics. Now they have advanced and very and the best specialists in the world. So they might not use it as much right now at Mayo Clinic, but they vetted those calculators and they're still valid. So yes, I think it's a tool that practitioners in the developing world should definitely lean onto. When I gave a talk a few weeks ago, I'd mentioned one that was very useful through Mayo Clinic for lung cancers. And if you're not sure, please use those tools. More money has been put into cancer research than almost any other diseases in the world combined. So there are tons and tons of tools out there. You're not alone. So use them and always seek help. Seek out to experts like this on this forum who are going to be available to guide you. Those are my 2 comments.
Yeah, thank you, Sydney. Thanks for the wonderful contributions and for always being there and for all what you're doing in Cameroon. So in the field of advancing cancer care in Cameroon, you're doing a wonderful job. I think the others will know in the future. So Claire Radiology is the upcoming place where we think that is going to be able to help improve screening in the Southwest, improve treatment and everything. So we're grateful. And one thing I want to add, truly, as you said, so if you consider all the research going on in medicine, 90% of registered clinical trials in the NCI and in the NIH are in oncology. So there are a lot of tools, guys. Every single day as I'm talking here, I didn't make this lecture to talk about new things, because new things can take us weeks to just talk about. So there is just a lot of tools out there that you can use, and there is no excuse anymore because of access. When I was still in queues, we didn't have access to anything. There was no internet, there was nothing. Right now, you guys can have access, and none of your professors can prevent you from getting knowledge and from being up to date. So any questions? Yes, Dr. Tim Fabrice, who is a surgeon.
Yeah, thank you, Munoh, and that's also all the lots of information that I think has been really edifying for us who are practicing here. And sometimes you have a disconnection about who does what and when should what be done. I think it's really great to have all this information and to try to give us a better view of what to expect from everybody. And I really like to insist on the multidisciplinary team management that we have always been advocating for. I think there's one thing that has come out of your presentation that I think we're advancing, because we all agree now that the threshold for mastectomy will probably be far lower here than what we find out there. And there's always been a problem for sometimes people get very aggressive with us surgeons. Like, why are you operating this patient? Why are you? Yeah, we don't want to operate the patient. We're asking always, what are you offering us? The patients don't get managed properly, they'll still come back with end stage, and you still come back to the surgeons to meet them when we can't do anything else. So when we get them early, we probably propose the patient early mastectomies. And it has always been a discussion sometimes with colleagues who are out there, and you're operating these patients for nothing. But we have no other option. I think it's very important that the other options should be built upon. Just getting proper screening, Dr. Francine said it. If we have early screening and early mastectomies, we'll probably have a higher survivability rate for our patients here. I think those are two things that we have to insist on, and why we build on the other resources that we think are indispensable for us to get the level of quality of life that is really insisted upon now for those patients. So I think there's one take-off message that I will take out is screening should be insisted upon. And I am one of the people that I think screening should be taken to lower cadre staff, nurses. Like, we need to train nurses to be able to detect when there are problems with this breast, when to get the GPs involved, get the specialists involved. But they are seeing 90% of the patients. And the patients are already coming to see specialists when it's too late. They're referring to the surgeon, it's probably stage 4. When we can't do much, you are doing mastectomies that are maybe just to become with fungating lesions. Remember the last time we had a presentation and I sent you a picture, like, what do you want me to do about this patient? I have her right on bed. Her problem now is this thing is septic, it's infected, it's smelly and all that. So our quality of life, I have to do a mastectomy that I know won't help her. But that will probably just improve her mindset, and I know it won't change our survival rate. So if we can do something as professionals practicing back home, and with your help, is really advocating for screening more and getting these women diagnosed early and treating them early, and preventing us from getting to the stages where we need all the complicated things that we know will come now. Thank you.
Yeah, thank you very much, Dr. Tim Fabrice. And thank you for all what you're doing and in your fight and advocacy for multidisciplinary management of cancer, especially with colored cancer, that I know very well. So you've hit the points which are very important. We need to provide care which is appropriate in our setting. At times we need to educate others too and tell them why we're doing that. Why we are opting for a mastectomy rather than a lumpectomy, because there is no access to radiation. We need to be able to tell this, advocate for this, and we also need to advocate at the level of the ministry. Why is it that in Cameroon even, only a private radiation operating facility is functional right now? L'Hôpital Général in Yaoundé used to have one. L'Hôpital Général in Douala used to have one which was functional. And why can we not expand this kind of care and train people? It goes back to training. And then two, as you said, building other capacity. I know we had a lot of discussion, Tim and I, concerning even capacity for pathologists to give you the data that you need, capacity for medical oncologists to sit in multidisciplinary rounds and be able to tell the surgeons exactly what they're doing. So this becomes very complicated back home. So it takes us back to the basis, which is screening. Prevention is better than cure. And I applaud you that it's good for us to try to send it. That's why this presentation was really meant for nurses, and we should be able to train nurse practitioners at different levels. So I would call on one of my big brothers here, Dr. Ivor Dita, for your contributions, please.
Dr. Munoh, thank you so much for the presentation. Brilliant as always. And we cannot thank you enough for what you're trying to do to improve the quality of care that we offer our loved ones that we've left back home and enjoying a wonderful time on beautiful couches out here in the US. The last time we talked about breast cancer on the Cameroon Medical Town Hall, I raised the question about whom we were talking to. I'm not sure who is on this, watching this presentation here, but certainly it sounds to me like we have clinicians who are on here. And the take-home message from what I have heard all along is prevention, prevention. How do we build capacity in terms of having what we need to screen and manage? A lot of the things you mentioned on here today, it appears like we don't have them in Cameroon. The testing that you require, it looks like it's a premium. So therefore, we are left with nothing else but to focus on prevention. I will again ask you, as also a leader who is also involved in the committee formed by the minister, what can you do, the stakeholders involved in policy making? How can we get this message across to them? While we can discuss the clinical aspects, talk about when we diagnose the disease, what we need to focus, as you've mentioned, is prevention. Those policymakers are not here. What can we do to get to those folks in order to build capacity back home, to screen people, detect them early, when we can do much to alter the course of the disease and hopefully the outcome for the patient? Thank you very much.
Wow, thank you. That's a difficult question as always, but I personally think advocacy is where we should go, meaning we should try to put cancer at the forefront of these discussions. Even in these meetings where we are, we should get the involvement of our leaders, community leaders. We should get those who are decision makers in the community who can actually push agenda like this, even in the parliament. We should be able to get those who are leading hospitals, who are directors of hospitals, who are at different regions, those who are formed in the regional councils, that this Cameroon has multiple health problems that we know. And focusing on cancer, we need to integrate it in such a way that is going to integrate into the overall health improvement of the country. So at my level, I think this is an advocacy I've taken, and I would channel it to the right channels in Cameroon. There are many other people here who do see the minister better than me too, whom I think they should be able to channel this. And the goal of this presentation today was more for us to educate the medical students, which some of them are here, some are not, to educate the primary practitioners to know exactly what is needed. And at their own different local levels, if they can advocate for change in Cameroon, that would be good. So I think we all need to advocate together if we understand that this is a real problem, and also advocate for primary prevention, which we are able to do rather than trying to seek to cure cancers, which our health system is fragile for now. So Dr. Dita, I will reach out to you too and see what we can do together in order to get this become an agenda. And I'll reach out to other people I know in Cameroon who are very influential and who can actually get the minister to listen to them. I think that's the way forward. I have several people here. There is Edir Francis. He has not even unmuted himself. He's a medical advisor in Limbe. Just so many people here who are able to advocate for policy change. So I think they should also be able to help out in this situation. It's a difficult way forward. Yes, please. I have Betila. Please, you can unmute yourself.
Okay, thank you, Dr. Munoh, for this great presentation. I have a more general question too. do you think conducting clinical trials in Cameroon can push the policymakers to take action into getting some of these drugs in the system? And if that be the case, how can we try to encourage some of these sponsors to recruit patients from Cameroon?
So I'll tell you a story. Cameroon there is right now, the Gates Foundation is trying to streamline the clinical trial process in Cameroon, which is a good start. And maybe one of these days, Elvis is going to give us an update about that, which is to make sure we have a well-written structure on what it takes to get ethical clearance. What are the structures in place? Do we have a committee that can supervise clinical trials? How have the other trials been going on? What has been the limitation? So we need to have this structure in place, first of all. The Gates Foundation is trying to do that. And clinical trials will always help every healthcare system in order to advance. But we need sustainable trials also. We just don't need to have people come in, do things, and then leave us with more problems. So I think it's one way forward, but Cameroon needs to put its infrastructure together. I can recall 2 years ago, I had one of a big company contact me and wanted to run almost a 3 billion clinical trial in Africa. We proposed Cameroon. We reached out to some, I don't want to call names because they'll know, we reached out to some high-level people in the ministry. And they simply said it was very sensitive a topic because it had to be in COVID at the time, sensitive a topic to even try to even discuss clinical trial in Cameroon. That was like 3 years ago. So we have a lot of fundamental problems going on. And also we realized that we did not have the structure in place to actually carry out those clinical trials. We can go through the government or we can actually use private initiatives. There are some private players in Cameroon who have run clinical trials, like Professor Mbanya and his group, and Professor Dumbe used to do that too. So we need to learn from their experiences and see what they did right. And there are several of them in Boya also carrying out clinical trials. So I support you. I think it's a right way to go forward with, but the question is from the US, I don't know how much I can do, but I can tell you there are people who are found in the town hall who have projects in Cameroon that are trying to empower the local physicians, nurses, researchers on establishing the right pathway for clinical trials in Cameroon. But I think in order to get these drugs, we just need advocacy at the level of Sename, and we need advocacy at the level of acquisition of these drugs. And Dr. Yawuba, who is in the Clinton Foundation, is working on subsidizing some of these drugs. I don't think he's here today, but he's the director of the Clinton Initiative. And I know he has a project with the Cameroon government on trying to get cancer medications. So there are people who are working on some of these things that we're talking about. I will stop here. Anyone has something to add, please? These are actually, yes, Professor Walaje is here.
Yes, can you hear me by any chance?
We can hear you today, yes, very well.
Oh, no, you can hear me. Oh, that's good. Thank you very much. Thank you for such a splendid talk. It's a real beautiful lecture. It's very timing. And I just like to, I'm Professor Walaji, just to let you know. I'm actually a surgical oncologist, which is not well known in Cameroon. But what I just wanted to tell you was that the management of cancer in Cameroon is very haphazard in the first situation. But I think in trying to tell us where the actual problem is. There is a serious system failure in the healthcare system. And in fact, to be able to manage cancer, such as breast cancer, we should begin simply by having breast clinics, okay? Individual doctors treat cancers as they would like to. And of course, from your speech, you forgot to mention that the diagnosis of breast cancer is actually based on a triple assessment, which many doctors don't know. You have the clinical assessment, you have the imaging, and you have the histology, the biopsy, and they work together, they complement each other. And you can only have 3 of those together. But do we have breast clinics in Cameroon? No. Okay, so there's a serious problem with our structuring of the healthcare system, which we must work on if we want to get things done. If we start with the basics, we shall have no problems. And now you mentioned the word, for example, lumpectomy. The doctors think that lumpectomy is actually surgery. A lumpectomy is a biopsy. It is simply an excision biopsy. So please, you should avoid those words. Breast conserving surgery is a wide local excision or a chondrontectomy. Okay, so if we start confusing those terminologies, we get really into problem. So the patients should be told that if they're actually going to have a biopsy, it's either the best would be a true cord biopsy or a wide local excision, or an excision biopsy. Okay, and I think what they mean, if you say somebody is having a lumpectomy, essentially they're just having an excision biopsy. Now, if you want to do a breast conserving surgery, you must get the results of the histology, and that is where your estrogen receptors come in, and the progesterone receptors come from the specimen. So if we don't have a breast clinic, how can you liaise with the pathologist on actually what you want? How can we liaise later with the oncologist? So I think that is what we should work on how we could actually get this breast clinic formed, where we have the surgeon working with the pathologist, okay, and the radiologist together. I think it's simple. It could be organized, all right? And then another point I wanted you to actually know is to discuss is that I think the people you should target as well should be the medical oncologists as well, because they're the ones who are actually doing this oncological treatment in Douala and Yaoundé. But I'm very impressed with all the information you've given with regard to the importance of the estrogen receptors. But you cannot get those receptors if you don't have the tissues. So the surgeons must be aware of that. Okay. With regard to screening, I think we should distinguish between screening and actually having a mammography done as part of diagnosis. Okay, we should really do that. Screening has its own limitations and its own disadvantages. There are a lot of lead time biases and the rest. And I think that what the government is doing by actually asking women to learn how to examine their breasts is very important. We cannot ignore that. Definitely we cannot. If a woman knows what is normal for her, she'll be able to know what is abnormal. So I think because we don't have the infrastructure, we should push on a woman doing her breast examination at a particular time of her menstrual cycle. Most diagnoses of breast cancer were actually done by the women themselves. We should educate them to know that what is an abnormal breast lump. It will be very helpful. So I don't think we should shy away from self-examination of the breast by these women and teaching them even how to do it. Now, mammograms are not as simple as you think. You see, they depend on the radiologist. The interpretation of these mammograms is very important. And we don't have the radiologists who could actually interpret these scans as they should do. Okay, so I think that those are the small points I wanted to add to your excellent talk. I think we should get things right. I think if we begin with just having breast clinics, whereby the GP knows, the general practitioner knows that this patient with possible breast cancer should be referred to this clinic in this hospital. And then the patient, the public should know that cancer management is multidisciplinary. No one doctor can treat cancer. The oncologist in Douala will tell the patients that they can treat their cancer by chemotherapy. No, chemotherapy is for the micrometastatic disease. And then another thing I wanted to point out is that locoregional treatment, locoregional management of cancer is for the treatment of the cancer. But to actually cure cancer, there must be an adjuvant chemotherapy for the micrometastasis. And you said that right. So the early treatment of breast cancer is just for the early stage cancer. And it is obviously either a breast conserving surgery or a mastectomy, depending on the indications. And it goes as well with axillary clearance. There are palpable axillary lymph nodes. Of course, it could be palpable. We don't have the sentinel node biopsy situations here. If the lymph nodes are palpable, are mobile, then they should be part of the axillary clearance while doing a breast conserving surgery and axillary clearance. But issue, of course, we know that you don't go as far as the level 3 lymph nodes. It's all part of the staging process as well once you get the lymph nodes removed. And then once you get the histology of the lymph nodes, you then send the patient now to the oncologist to carry out the appropriate adjuvant treatment. Okay. Now, the indications for breast conserving surgery are for small tumors which are less than 5 centimeters, tumors which are away from the nipple, the ductal carcinomas in situ, which are less than 25% of the breast. Now, we cannot say anything wrong about Halsted. We cannot condemn Halsted. The father of modern oncology, because he brought out the principle of clearing the tumor with the associated lymph nodes. Okay, his own problem was that he was just a bit too radical. So essentially, simple mastectomy plus axillary clearance is a locoregional treatment. It's good, it's excellent. But if the lymph nodes are positive, then you should have adjuvant chemotherapy. So, so putting down Halsted was only for the cosmetic aspect of his surgery. He was very radical in clearing the pectoralis major with it as well. That was too radical. It made no difference. Okay, so breast conserving surgery is really advocated, and there's also an indication for simple mastectomy, not the Halsted mastectomy. And you're right to say if you do, you cannot give radiotherapy to the axilla because you will cause lymphedema and other complications of that. So now if you do a breast conserving surgery, as you rightly say, you must have radiotherapy because for the rest of the breast as well. Okay, that is why you need radiotherapy. If you do a simple mastectomy, you don't need radiotherapy unless if the histology comes back to be very aggressive tumor, then you may have to add adjuvant radiotherapy to that. But the problem we have in Cameroon is that the doctors simply do a lumpectomy and they think that that is breast conserving surgery. No, you cannot clear a tumor by just cutting around the tumor. No, you must do a wide local excision or a quadrantectomy. And that is where the margins are being told, are discussed by the pathologist. If you do a lumpectomy, the margins will be affected. You're just wasting your time. So a lumpectomy is simply a biopsy, an excision biopsy that they've been doing. It's not a definitive treatment. So we should avoid those words lumpectomies. If you're doing breast conserving surgery, it should be a wide local excision or a quadrantectomy.
Okay, so
yes.
Yeah.
So I think this is very important. We should know what we're actually doing. And yes, I think those are the main points I just want to add to it, just to add to what you said. It's simple if we have a systematic system in the country where there's there's organization and people know what they can do and what they cannot do. Okay, a lot of the surgeons just do what they want to do, and there's a lot of myths, as you know, in Africa still. People do not understand the role of multidisciplinary management. Most people do not understand that. No surgeon can treat breast cancer on its own. You can only cure breast cancer if it's early by locoregional treatment. But if it isn't, you're wasting your time, as you rightly said. If there's metastasis, you're wasting your time if you're just concentrating on the surgery. So in terms of the staging of cancer, it's very important. If the stage 1 or 2, yes, it could be operable, but the stage 3 and 4 are non-operable. You must send them to the oncologist to see if there's some adjuvant treatment could downstage the tumor before you think about doing some sort of a mastectomy or salvage mastectomy. So there must be a multidisciplinary team in management. At the moment in the country, there's nothing like that. The oncologists work on their own, the surgeons work on their own, the pathologists work on their own, and it cannot work. It cannot work. Now you mentioned about the gynecologist. Again, I like what you said, but unfortunately, if we say that the gynecologist will be very annoyed, because in Europe, the gynecologists have a role in managing breast cancer. The gynecologists are not as aggressive as the surgeon in managing breast cancer, I tell my patients, because they don't like they don't like clearing the lymph nodes in the axilla. They just do a simple lumpectomy and they think they've done everything and send for the oncologist. So in fact, that is why they may have a point in saying that breast cancer is a systemic disease, and it is true. The outcome of treatment of any cancer is predetermined by the presence or absence of micrometastasis. So we should really know that most of these cancers, as you said, are already stage 3, stage 4. They have micrometastasis involved. And we should ensure that we stage these patients properly before attempting to do the sort of local regional treatment that we do, which is actually useless.
Yeah.
So local regional treatment is simply treatment only. It's different from cure. Excellent. And I've learned a lot from all what you said, but I think we should start by having at least a breast clinic. Don't you talk about, because in that way, breast clinic, you have at least 3 doctors working together. We should start having that before. And of course,
so
we
Professor
need
Waleji, I want to
Yes.
give chance for others for questions, but I'll give some certain reactions which are important. I think it's very important, as you said, to get breast clinics. Very important for us to get breast clinics where we can have multidisciplinary approach. And it's important, and this is what I really lay emphasis on, that we start practicing evidence-based medicine in Cameroon. What is evidence-based medicine? Evidence-based medicine is when you practice medicine based on clinical trials and not on what you feel or what expert opinions say. So evidence-based medicine is something which I feel we should do more often in Cameroon, because if we do evidence-based medicine, our students will learn what the facts are.
Indeed, but you see, the thing is, we don't have the structure of evidence-based medicine unless we are organized.
Yeah,
you see, the doctors, the surgeons, unless we organize ourselves, we cannot practice evidence-based medicine. Because as you know in Cameroon, the country believes that a doctor is a doctor. There's no hierarchy in Cameroon. They don't really believe so much.
I know, but we need to start training. We need to start training our students to understand. I trained in Cameroon, so we need to start training our students to understand that it's not about what the doctor thinks, what the surgeon thinks, or what the gynecology thinks. There is data proving that what you're doing, either you're causing harm or you're doing good. Why is this important? It's important because we have had clinical trials back in 1960 that actually showed that Holstein mastectomy was the wrong thing to do. And this data has existed since 1960. No, wait, let me just finish.
But nobody does Holstein. Nobody does Holstein anymore.
So this is very important.
That the surgeons, no, let me just tell you, the surgeons, they're never trained to do Holstein anymore. Holstein is a very aggressive, mutilating type of surgery. So surgeons don't do that at all. We do now a simple mastectomy. Okay, we leave the pectoralis major and clear the axilla to the level 2 lymph nodes if the lymph nodes are operable, if they're operable, obviously. Now, if you approach the axilla, then you don't need to give radiotherapy to it because you just cut lymphedema and other things.
No, so that's one thing. I will go back to that, Dr. Waleji. Radiation, a need for radiation. So please, no, wait, please. The need for radiation depends, there's clinical trials. So the need for radiation depends on how many lymph nodes are positive. So I don't want us to give wrong information. I don't want us to give wrong information to medical students. So these are trials. I'm not talking about what I think. So if you want to decide on radiation to a patient, if all women who are premenopausal with positive lymph nodes need radiation, all women
I agree with you.
Who are
what I'm saying that if you are giving
and having more than, because what I'm telling here is it's very important in Cameroon that we get to this point where we understand that medicine should be evidence-based. And what is the importance of getting evidence-based medicine? The importance of evidence-based medicine is that it helps everyone to carry out treatment based on guidelines, not based on emotion. Example,
I just want to add to what you said.
Every patient who gets what a partial breast lumpectomy, who gets a partial breast surgery or
breast conserving surgery.
Listen, breast conserving surgery or mastectomy, which is not double mastectomy, needs, if they are ER/PR positive, they need adjuvant treatment. It's not.
Oh, very true.
So that is why referral to a medical oncologist should be standard of care. And I'm saying this because there are so many, I would want to go through the trials so that people here understand that all what we're discussing is based on trials. So the NSABP4 was a trial that made in place that we can do simple mastectomy. The skin preservation trials, where the trials were retrospective trials, the NSABP6 trials were the trials that showed that lumpectomy is equal to mastectomy plus, lumpectomy plus radiation. The question of semantics, what you call quadratectomy, lumpectomy is all about semantics and words.
Yes, and but it's very important that we get.
But what we should insist is that it's breast conservation surgery.
That is what I'm saying.
So
that's what I'm saying.
Semantics and words. But I want medical students to go back with this information, which is very important for me and my lecture. That what they should know at the end of this lecture is that evidence is not based on individuals. Evidence is based on clinical trials. I'll give you another clinical trial. The NSBP B18 showed that for women, the question was, should we do chemotherapy before surgery or after surgery? There is no difference. But we know that by doing chemotherapy before surgery in patients who have triple negative and those who have HER2 disease, we are able to escalate treatment after chemotherapy and after surgery, depending on the amount of tumor which is left. And the question of centenary lymph node and axillary lymph node is a big question with multiple trials. And the trials have shown that if you have a clinical lymph node negative disease, in these patients, they don't need radiation. But if you have a positive clinical lymph node, in addition to your surgery, they do need radiation. And it's important that when we're living, this is very important that we understand that the management of any disease, cancers, evidence-based medicine came in to take away. Expert opinion is actually the fourth level of evidence, meaning is the very last level of evidence. Once you have evidence in place, people should stop practicing what they lack. And Cameroon needs to get to that point. When there is evidence in place, there should be no difference between what the gynecologists are doing and what the surgeons are doing. The appropriate thing to do is that people should go to school, they should be well trained to be breast surgeons, and they should acquire that knowledge. And why? Because if they do that, gynecology oncologists are very busy. Gyn oncology is a big specialty in its own and does not include breast in any country. It's very important that we know.
I agree with you.
And gyn oncology is a big practice because it does not include breast. Breast oncology is a surgical specialty. And what we are leaning towards, if you go to the breast experts, like Helena will tell you in Slum, we are moving towards not even doing surgery for most patients. That is where the research is going. That is where the research is going. So the research started with radical things. I don't disrespect. Hosted is a father of a lot of surgery, but the Hostedian policy kept medicine hundreds of years backward. Why? Because we thought that, I will tell you today, what we do in oncology is going to amaze you. We do circulating tumor DNAs, and we are finding out that a lot of patients with simple localized disease already have cancer everywhere. And that's the goal. And that is the goal behind why every breast cancer patient needs adjuvant therapy. The question is, what type adjuvant therapy do you need?
Indeed. And you, Prof, let me just intervene there. You've really said it all well, but just for you to tell the medical students, if radiotherapy to the axilla is excellent, but you cannot do surgery and radiotherapy at you do surgery if you've done radiotherapy to the axilla. You can, if you do surgery to the axilla, you cannot have any further radiotherapy to the axilla. So I agree with you. You must make a decision on whether you give radiotherapy to the axilla or you're going to carry out surgery. Because if you have two of them together, you have lymphedema and severe complications. Okay, so I agree with you. Yes.
So, Dr. Irwan, I don't want to go into this. Is a very interesting debate, but my end message usually to the young students in Cameroon is that we can have a whole talk about this, but is that the young students should know that medicine is evidence-based. Medicine is based on clinical trials. Medicine is not based on what people think and what people want to do in Cameroon. And we have reached that stage where we are educated enough, we should be able to have evidence. A lot of you can get to up to date and see what it's being said by everything someone is practicing. We should either provide the standard of care or provide something similar to the standard of care if we are unable to provide the standard of care. I think that is so important. And tomorrow we'll continue with the rest of the lecture, but we have questions now. Erwan, please. You can unmute yourself.
Yeah, thank you for what you said and also for Wedeji. I want to raise something particular in Cameroon, especially because I had the opportunity to work in Ghana, where I was trained for breast surgery, and I'm also working in Cameroon. The mindset. If there is something to teach to the students, the mindset. The mindset of the patient and the mindset of the clinicians. Why do I say it? I know this is culturally based, but people think that if you have a good intention, you cannot do harm. So people usually judge you according to the intentions you have. If they feel like you had bad intentions, then they start blasting you. If they feel like you had good intention, they will never blast you. But things are going to change. That's why I want to talk to the medical student that if you expect that people will still be going like, oh, he just wanted to do something nice. When we were medical students, you could never hear that a guy who had a necrotizing something in the abdomen, when we remove all the necrotic tissue, people will say that we are doing some organ something at the hospital center. That could have never happened some years back. But you see, just because of an intention, what people think we are doing. So we have to be careful because the evidence base is what is going to save us. Because when you are going to take you to court and you can show that you did evidence base, usually there's no problem. And the intention, what do I say about the mindset of the clinicians in Cameroon? I told you, I have tried to get in contact with the oncology unit in the Hôpital Général, the oncology unit with Hôpital Bonastama, which are the two that were there when I came back. They don't want to work with a doctor who is not part of their team. It's like they think that they are the ones who have the knowledge and that's all. You even send a patient, like for example, you see a patient, I see a patient. I stage the patient, I say, no, this patient needs to be discussed with the guys. You want to talk to them on the phone, you can't. You send the patient to them, explaining this is what is happening and things. They start taking care of the patient, they never give you a feedback. As if you didn't know what to do. When you want even to call them, and then sometimes after, when the patients come back to you, you come and discover they did something wrong with the patient. And then you don't know what to say. You can't talk to the patient, telling him what happened and everything. And I told you that we had the same thing with the Hôpital Général. So I believe that what they call Société Savante in Cameroon of oncology and everything, they are not producing no guidelines. I think they are useless. They are very happy to show that they are doing some nice this thing, but really the Société Savante in Cameroon are totally useless. Maybe pediatricians, the SOCAPE, maybe they are doing something. They have issued some books on guidelines on how to treat some pediatricians' basic disease. But the other Société Savante, they are useless. They are just organizing seminar and everything to go and take pictures. That's all. They're not producing nothing, no knowledge for the student to have a guide. I hope they are here, but I'm almost sure they will not be around, or they will not never answer what I'm talking about. And as I'm discussing with you, I'm on webinars on how to do, how to treat cancers, how to manage cancers. You go on those webinars that have been organized all over the world. You are looking for Cameroonians who are working in Cameroon. They never go and try to have a new knowledge. They are just happy. Now they are saying that they want to get money. What you are talking about lumpectomy, quarantectomy, all those things, know that when a guy sees a patient in Cameroon, he says, let me get my money on him before he dies. That's what they have in their mind. That's what they have in their mind. The man is not like, how can I help this patient? The surgeon will stay there and say, okay, let me do my lumpectomy and everything. That's why they will never advocate for, how do you call it, the immunohistochemistry. They will never look for that because he has done his job, his surgical part, and he says the rest is for the oncologist. So I believe that what we can do, we can try and put down some guidelines that can be helpful for Cameroon on papers, so that we can make them circulate, so that the resident can read it. Because when you're talking about students, you know that even the residents are not trained for that, because who are the bosses? Are they doing the job? No. So if we can do some guidelines, writing some guidelines and make it circulate for the students, that's good. And from time to time, we update them. That would be good. Then there should be absolutely collaboration. You expect breast cancer. You know, Cameroonian, we are not trained to work together. That's something very simple. Everybody thinks he's the most intelligent guy. So I just said, now that we have this technology thing that we call Zoom or WhatsApp, simple thing, we can discuss a case. I asked Hôpital Général that let us sit down, discuss about what could be all the information a patient should have in a folder. We create a folder for a patient that will be the one that we'll use everywhere. Let's just say even in the region, in the literal region. You write everything that you want to know about the patient. The patient can do things from everywhere. Now, there are more private clinics than hospital, than public hospital in Cameroon. That one is known. So you can have some public hospitals, they don't even have mammograph. You have to send to private ones. That's the truth. MRI. How many public hospitals have MRI? That is just say the truth. So we can say that for a patient, we need to have this, and this. And then among ourselves, we know that, okay, this guy is doing this well, this guy is doing this well in this area. And then we have all the information. And then we can discuss as we used to discuss HIV patients in those days. You remember, Munoh? We were discussing
Yes.
HIV patients, then we decide on what to do, what is the next move. So we can
I used to be in charge of the HIV for some few weeks, so some few months before I got posted to Mancon.
I'm doing with you. When I have a case, immediately I have the case, I start discussing with you, because I think that it's not a case that should manage alone, but I was trained to know that I can't manage that case alone. So automatically when I have the case, I start gathering the other practitioners. But in Cameroon, that's not the case. The guys are outside trying to know that, I will make my own money, and then before that patient dies, that's not my problem. So there's a problem with the mindset, and I hope the students who are on the forum listen to what I'm saying. Be careful with the mindset. You have to review. You have to update your mindset. You can't work together. It's about health. It's not about your pride. Really. That's something that I really want to raise here.
Thank you, Dr. Erwan. You said a lot of things that are very important. I will just summarize and then I would react to one or two. As you said, collaboration is key. And having people who are specialized in a specialty being willing to collaborate is so important. And it's all about, it goes back to our culture and our training. And it's important, especially in cancer, to understand that cancer is a multidisciplinary approach. So as I told you, I see 30 cancer patients a week. Breast cancer, I see 25 cancer patients a day, but I see 30 breast cancer patients a week. We do have a cancer tumor board, which is run by the breast cancer surgeons. And those who are involved are the plastic surgeons, the breast surgeon, you have the radiation oncologist, the medical oncologist, and there are so many clinical trials going out, and everybody puts in their opinion based on clinical trials and what we are doing for the patient. It's not based on personal opinions, and this should be important. And you are bringing up a topic where what the data occurring in radiation oncology, I cannot keep up to date with it. No matter how much I try, I treat more than 300 cancers. What is occurring in breast surgery, I cannot keep up to date, but I keep up to date based on the fact that I attend breast surgery and I have more than 5 breast surgeons in my practice. I attend breast surgery tumor boards every week, and we get to talk about all complex cases. Everyone learns, everyone gets up to date, and the breast surgeons are the ones who tell you we no longer do this. We don't have to do this. The outcome doesn't change. And that is why in Cameroon, the problem is so deep that we need continuous medical education, because a lot of our students are being also taught by people who are not up to date. And it's very important. And I've told the students you can break yourself from that chain by getting yourself information online. These students need to break themselves. I trained in Cameroon. If I'm talking that I didn't train in Cameroon, I know Cameroon so well, more than most people. I actually did residency in Cameroon, and I can tell you, I can spend my time criticizing Cameroon, but I don't want to do that. That's not the goal here. The goal is to build things. It's our time to be able to give back to those kids who are back home and make them better. My end of year, 7th year exam was a patient who had ovarian cancer. I thought I knew everything. It's now that I'm a medical oncologist, and one of my professors almost killed me. Let me not give his name, during my 6th year medical exams. And I do not know how, then I had to know that. I don't know if you can remember, you guys were called to ask if they actually taught us that. I don't know if it was you or Medicare.
I remember, yeah, I remember.
In my final year exams in Qs, I had ovarian cancer. And the professor, and I still remember those things today, because everyone was in my group, that was my final year exam. We do have situations, and I just attended tumor boards in La Cantine. I was so disappointed because the mentality has not changed. None of the tumor board was meant, like the one we run in Bamenda is excellent. None of the tumor board was meant to improve the patient's standard of care. People gave opinions which were not factual. People gave their personal opinions they have never read, and nobody talked about the patient who was in front of us and what to do. And there was a question I said, and I asked myself to them, why was it important for you guys to ask if we had to do a CT scan to diagnose diverticulitis? Est-ce qu'on peut diagnostiquer un diverticulite? And that was like a 15-minute discussion. I asked, like, what is the relevance in this patient who has colon cancer? It's just people want to show the little things people know, they want to show their superiority over others. And we need to get out of that mindset. And the problem in the training, in why pediatry is doing better than internal medicine, goes back to our core training, Irwan. Sadly, I would say it. There are some departments, the fact that we train our oncologists without having experience in internal medicine is a big problem. The fact that they are trained where the other subspecialties that need to understand cancers are not well developed is a problem. The fact that they don't run tumor boards and multidisciplinary rounds, they will not even learn to collaborate. So this becomes a big problem. I do collaborate with a lot of oncologists back home who did not train in Cameroon, who are willing to share what they have, and we can learn together. And they can learn with others. Even when I see a patient here, I'll give you an example. I see a patient who has, for example, breast cancer and ER/PR positive, lymph node positive. I call the surgeon. What do you think? Do you think that you can do this surgery up front and let me do adjuvant therapy, or you think that this mass is too big and all of that? Because for the standard of care for ER/PR positive, HER2 negative is surgery up front. The surgeon tells me that with this case, I want to do breast conservative surgery. Can you please get to do me adjuvant chemotherapy first, and let's run, or adjuvant endocrine therapy, then I do it, because you need to collaborate. It's an interdisciplinary team, and that is where we are failing. So everyone, thank you. And I hope each of this talk was meant today for medical students also. I hope we get to bring them here. And I want to hear the opinion of Professor Joshua Tambe. That's my classmate too, and he's a radiologist. I see you have been writing in the chat. I don't know if you want to say something.
Thank you, Munoh, for giving me the opportunity. I really don't want to say much. I think we have really spent a lot of time. But as you can see, I just gave some of my contributions in the chat section. I think it's an excellent presentation. I'm a radiologist who is very much interested in oncologic imaging. And I even co-authored a paper with Professor Weleji on breast cancer. So that's my area of interest, imaging in oncology. So I'm very, very interested in oncology. So I do not want to miss any opportunity to learn something new about oncology. I know nothing was said about the imaging aspect of it, but nevertheless, I got to learn a lot about the medical aspects of oncology. So I keep on encouraging my students to participate. I encourage other physicians to participate because when you stop learning, that's the only time you really get old. So it's not an age, not a figure of just numbers. You know, each time you stop learning, you stop growing. And I'm very, very appreciative of all what you have been able to do. And I think that one day we'll be able to get to where you are. The only question I had to ask was that where are our own oncologists in Cameroon so that we could, through this presentation, kind of settle down on some things and adopt what we can do locally in our context. Otherwise, if these key actors keep on being absent from such presentations, then we still continue to function in a fragmented clinical setting, where, as everyone said, he is a surgeon who is also interested in oncology, but he cannot get to communicate with the medical oncologist for some funny reasons. If we had these interdisciplinary tumor boards that included physicians from different facilities, it becomes important for us to collaborate and do everything for the sake of the patient. But nevertheless, as you said, the objective is not to criticize, is to actually identify the lapses in the system and see how we can improve on that. Because you like it or not, oncology is the medicine of the future. I like using that expression a couple of times. Oncology really remains much of what we're going to be doing for those of us who choose to remain in clinical practice. Oncology is the medicine of the future. The non-communicable diseases are going to be there, and then the infectious diseases are going to be there. But all of these underlying conditions keep on changing the landscape of oncology. So whether you like it or not, we have to get interested in oncology because either we are going to treat a lot of patients with oncology problems, or we are going to become these patients ourselves one day. So I think it's very, very important. The landscape is changing and oncology is very, very important. You know, today we talk a lot about climate change and the impacts on cancer, a lot of changes in lifestyle, and also new emergent and re-emergent infectious diseases. So I'm very, very passionate about oncology, and I thank Munoh so much for his time and his response, so that we do not become just critics of the system, but what Munoh is doing is trying to give back. And I've already invited Munoh. When next he comes to Cameroon, we have a tour through some of our medical schools.
And I accept that invitation, and I will be in Cameroon sometime. Maybe I will let you know in February, and I would really want to attend some of the conferences in Cameroon. I have a lot of classmates who are involved, and I want to thank you for the invitation, and I'm going to accept it. My specialty is actually head and neck with lung cancer. That's my subspecialty. But I do tend to see a lot of breast because we have an overflow in breast cancer. So, and maybe we'll look for time to talk about prostate cancer, which is very common in men in Cameroon too. So yes, thank you, Prof. Thank you, Professor Joshua. He's one of the people I know who is up to date about everything. Joshua can always surprise you right from medical school. So, and before we conclude the session, I don't want to keep you guys here. Tomorrow will be an interesting day. We are going to talk about, is the second part of the lecture. We're going to talk about metastatic disease. Metastatic disease is where things have changed. I've taken a 360-degree change in oncology. We do amazing things here. I don't know when they are going to reach Cameroon and other specialties. Right now in oncology, we are We are moving away from chemotherapy and more into targetable therapy, personalized medicine. Everyone gets a next generation sequencing. We are able to tell there is something we call metastatic C disease, those who have circulating tumor, meaning you have a little cancer here, but you have cancer circulating in your blood. We already know you're going to reoccur. We have amazing things happening in oncology, especially in lung cancer, which is not very common in Cameroon. We have more than 20 targetable mutations that have less side effects, like just as you're taking diabetic medications when I'm treating cancer. And I can increase survival for multiple patients with months and years just by giving them a pill for multiple cancers. So things have changed. Tomorrow we'll get the tip of the iceberg of what has changed in metastatic disease. And we'll finish the lecture by talking about special situations in breast cancer, meaning breast cancer and pregnancy. What do you do? Male breast cancer, what is the evidence? So we'll talk about that too tomorrow. So tomorrow will be a good day. But my take-home message today, really, to those who are here and to the medical students is that, one, prevention is better than cure. And I think we need to advocate for preventive medicine in Cameroon. As Professor Joshua said, we cannot shy away from oncology. It's coming. We are all getting older, and the biggest risk factor for cancer is age. All cancers, breast cancer included, is age. The more we age, the more we get cancers. We need to be able to screen, diagnose early, and treat early. The second part of my message is collaboration. Those who are surgeons in here, those who are gynecologists, those who are medical oncologists, like Dr. Francine and the others, we need to collaborate. They are doing a wonderful job in Bamenda. I cannot tell you how wonderful it is. I've attended and I've collaborated with both tumor boards. You cannot believe, that's why they say it's not how big a hospital is, it's how inspirational the people are and willing to change practice. So the practice change in Bamenda is already palpable. You could see it palpable to the patients. The next thing I want to talk about is something that goes to the pathology department, and I will keep saying it even tomorrow. No patient with breast cancer should ever be treated without getting an immunohistochemistry staining. It is illegal. It is kind of, how do I put it? It is actually criminal to do that. You will not defend yourself in any court of law. I have seen, they send me pathologists almost every week for patients in Cameroon by different colleagues. And I still see, now it's less common, but I still see people not doing the estrogen and progesterone levels for people who have even had treatment in very big cancer centers. It is not about how much money we want to make out of a patient. We should get and advocate for the best thing for the patient. Most of those patients may not need chemotherapy. The last thing I want to talk about, it's more about biopsy. And this is for the surgeons. Fine needle aspiration should not be done for breast cancer, please. Do a core biopsy. The instruments are not very expensive. Get it, do a core biopsy for these patients. Why? Because if you've ever been a pathologist or looked at slides, I looked at slides before, once you do a fine needle aspiration, you're doing cytology. There are very few good cytologists, and you don't have architecture. So you cannot tell the difference between DCIS and invasive breast cancer. You cannot even do immunohistochemistry standings. This makes it difficult. Erwan will tell you a story, which we spoke about together, where even the oncologist did not know that you need a fine needle biopsy. You need a core biopsy to get immunohistochemistry standings. This becomes sad. Now, I do not encourage excisions when you see a lump. I encourage you to biopsy it so you can plan for the surgery better. That is how it's done, because you plan for the surgery and you do a good job. So my advocacy really is in those levels. And please, Always share these trainings to your medical students so they can attend. This is Breast Cancer Month. We're doing breast cancer. There are other cancers we're going to tackle in Cameroon. And I think next year we'll come back to this because it's never too late to keep educating and for practice to change. I can tell you that from the time I started talking about breast cancer, I know many people who have changed their practice. And I know many people who ask for estrogen and progesterone level upfront. And I've had multiple questions about clinical cases which were interesting, even challenging to me what to do. I've had 90-year-olds being presented to me from Cameroon, what should do with them. So it's getting very interesting and exciting. I just want to invite you all, same time tomorrow, we'll have 2 hours discussion. And please, if there are no questions, we'll end it here today. The goal was to do this for a total of 3 hours. And it was a wonderful question and answer session. I want to thank Professor Waleji for his input. I want to thank Dr. Iran, Dr. Ivo Dita. I want to thank Professor Tambe Joshua. I want to thank Dr. Umbaku Kingsley for what they're doing with ISO, and Dr. Francine, what they're doing in Bamenda. They're doing a wonderful job. And please, if you have any questions before I end the session, then let us know. We have just 3 minutes left.
Don't forget that Dr. Bronhida had to drive and follow your presentation.
Oh, yeah,
she got to her office. You can imagine the risk she took while on the steering wheel. She's
the best, so you know that.
No, I couldn't miss this, even though, I mean, my own end is the sickest patient. I think tomorrow will be more interesting since I'm also a pulmonologist and I do collaborate with the oncologist and pathologist for diagnosis purposes. But, just like, I couldn't miss this. I had to reschedule my schedule just to be able to listen to you, because there's always something to learn. And I just believe that, knowledge is power, like you said. Well, we have to always try to be updated. Even if it's not your field directly, there's always something to learn. And I really hope that maybe our colleagues in Cameroon are a little bit more open to know that we're trying to collaborate and not, feel like, they always have to be on the defensive side. Unfortunately, it looks as if, and I don't want to be, polemical here, the Anglophone side of Cameroon, maybe it's the Anglo-Saxon, even with my collaboration with them, they are more open. We always have this challenge when it comes to the other side, French side with collaboration. So I'm hoping that since, Munoh, you have, maybe the ears of the minister, some of these things may have to be addressed. I know it's a long shot, but sometimes if they put some things in place, that may also maybe slowly change the system also, because we can talk to the medical students, yes, but we have to also address this at the level of the system in general. And it may be a long shot, but this is a new generation. I think we can start somewhere. So thank you very much for all you do.
Yeah, thank you, Dr. Brunhilde, she's a critical care and pulmonologist, and you guys do an amazing job. And I think Cameroon needs a lot of you, a lot of input into what you guys do, even trying to get tissue in Cameroon, the diagnosis of patients with lung cancer, EBUS, EUS, those are things that are totally lacking in Cameroon. Even biopsies, interventional biopsies for cancer. I always say something to my fellows and my residents: no tissue, no issue. And you guys help us to get tissue. Another department that we need to really bring up to date in Cameroon is interventional radiology. Because if we don't get them up to that par, oncology is not going to move forward. So oncology needs collaboration. And I cannot tell how many times I call pulmonologists to beg them to get me tissue for one thing or the other. So thank you for all what you do. Cameroon needs you too. And I know what you're doing and how much you are involved in helping in Cameroon. I've given up. The local level. So
we have to give back to our community.
I know how much you help individually, system-wise, and everything. Thanks for what you're doing.
Thank you.
Yeah. So, if last words and
hello.
Yes, please.
Yes, this is Dr. Wirba, gynecologist, emergency physician. Thank you very much, Dr. Munoh. A lot has been said. I am grateful. Ronhila just said that we in Cameroon, sometimes we are locked up. Yes, I think the mindset and every other thing, like you said, they have very, very, very factual issues. The greatest problem that we're having is that of organization. And that is particularly, I want to keep thanking Dr. Munoh, because we're on the right path. I personally should tell you that I've learned a lot. I just cried a few minutes. I came in late and, it is, but my major suggestion tonight was that Dr. Munoh, please take up the challenge, create a small WhatsApp group of volunteers, those who want, we can start the Tribune board even on the WhatsApp group, and we keep on. Things have moved, and yes, you emphasize on the evidence-based. We still have people who have complexes. I am this, I am that, so I am the only one who should do that. No, the breast cancer issue in Cameroon is a big challenge worldwide because we still have our economic environment is not good. Patients don't have money. Before you waste 1 or 2 minutes and their resources, they run out of resources and they cannot continue. There's no systematic screening. The cultural factors still come in where some things that they will pray, and by the end of the day, we have problems with early diagnosis, which is the key, and it becomes so expensive. So really, the awareness you are creating is so wonderful, and we're happy. Personally, I'm very happy. I wouldn't have time to share here what we are doing at our own health facility. I am in a private clinic here in St. Joseph. I'm also the gynecologist by Fair District Hospital, but we are not sleeping. Thank you very much. Your impact is being felt very greatly. Thank you.
Yeah, thank you, Dr. Weber. Thank you very much. And I think we have collaborated together, and you're a wonderful big brother and mentor. So thank you for all what you do.
Thank you.
Yeah, so for now, I'm going to end the session, and we will see you guys tomorrow, those who have a chance to meet us. We'll talk about metastatic disease. Gynecologists will be needed too. We'll talk about breast cancer in pregnancy. We'll talk about breast cancer in men and the way forward, what differs in these situations. But metastatic disease is really where a lot has taken place. If they are not oncologists here, I will not go into certain details, but I will just try to keep it as basic as possible. So thank you everyone for attending, and wish you all the best, and God bless you all.
Thank you. God bless you too.
Thank you.
Thank you. Thank you, Dr. Munoh.